Yasin to give an introduction of Swapnil Hiremat, and then we play the video, which is recorded by Swapnil Hiremat for Mumbai Nephrology Group, more for Mumbai Kidney Foundation, but we thought we'll have it combined. Thank you.
Good morning, everyone. I hope you enjoyed yesterday's session. We have again a very interesting interactive session planned for today. And for the morning session, as Thanas has said, it's a video recorded talk by Dr. Hiremat. Dr. Hiremat is an alumni of St. J.S. Medical College, and now he's a faculty member at University of Ottawa in Ontario. I am sure all of you have seen his work on Twitter, and he's a part of NephJC as well. So we're going to play his session initially, and then we'll move on to the next session subsequently.
Okay.
Good morning, good afternoon, good evening. My name is Swapnil Hiremat, and I'm a nephrologist in Canada. And welcome to this edition of Adventures in Critical Appraisal for the Mumbai Nephrology Group. Thanks again to Dr. Umesh Khanna for the invitation to talk about a topic that is very close to my heart. So I don't have any disclosures for this topic. I don't have any pharma funding. I have some grants and I'm a member of some guidelines, but this has no bearing on the talk today. I am a co-founder of NephJC, which is a Twitter-based nephrology journal club in which we do a lot of critical appraisal. And I'm a non-believer on publications, especially new drugs. So on the spectrum of being a believer, I'm more on the skeptic to a cynic side, and I often look forward to reading papers just to find faults. So the objectives of this module is to stop believing published findings at face value, to get a taste of some critical appraisal for trials, and to avoid common errors while reading and interpreting trials. And this should be a frame of mind. So this is Jonathan Swan while he was interviewing the former President Trump, looking at the papers. It's like, you're reading a paper and you're not like, oh wow, this is wonderful. You should be like, why did the authors do this? How do they make sense? That should be a frame of mind when you're reading a paper to get the most out of the critical appraisal part. And I've written a blog which you can read at this link on how to read a paper. And briefly, what I do like to do is to print it out. I know the trees may not be happy, but if it's a paper you're going to change your practice on, it's really important to print it out and read it very, very closely, as well as a supplement. You read the title and the abstract, and it may seem superfluous, but it's really important. The abstract should be able to give you a sense of what the paper is doing, and I would read every word very, very carefully. Then you skip the introduction, you go over the methods very briefly, look at the figures and tables, figure 1, table 1 in particular, and the main results and tables, and then you read the text of the results. And while you're reading the tables and the figures, you go back to the methods, right? At that time you read the methods very properly. Read the supplementary appendix because it often has more methods and more results. You can read it even while you're looking at the main results. You look up the author's names, affiliations, funding body, and if at all you want to read the discussion, read the limitation section. I would say you should stop there. Don't read the introduction or the rest of the discussion unless you're really, really puzzled about some things. And they are the least helpful parts of a paper. So it's a non-linear journey, right? It's not like a highway on which you can drive and just one thing comes after the other. It's more like this, where you go back and forth and you look at this and you look at that, you consult some other paper. Don't think about reading the methods and completing all the stats and analysis before you go to the results. One of the key things, of course, before you start reading a paper is that prior knowledge is extremely important. You need to know what the topic is about, right? For example, why was the study done? What do previous studies show? Was this study really necessary? And how do you get that, right? Don't look at the introduction for that. Go find a review paper on it. If you have got access to up-to-date, read up-to-date on that topic. Look at previous trials. If you don't have access to any of these things, ask a friend or a colleague to know more about the topic, about why this trial was done. Anything else, but reading the introduction is a useful way. And this is essential. I think you have to have some background about the study, about that area before you start reading a paper. And treat the introduction like tainted material. So once you're looking at the methods, right, the one thing to think about, and I'm talking about trials here, is that is this even randomized? So look for the method of randomization, and some of the key red flags are if they say sequential, consecutive, alternate assignment. that sort of tells you, those kind of words in the methods mean that it was probably not a trial. It was not a randomized trial, though that may be the claim in other places. And in the methods, again, you skip the introduction. In the methods, the few things you can quickly eyeball are, you look at the study setting, you look at the primary outcomes, the inclusion-exclusion criteria, anything else that stands out. But don't get bogged down in the fine details, right? You move on, just quickly look at it, and diabetes, CKD, GFR 60, okay, move on, and then come back to the finer details later. Then move on to the results. Look at all the figures and the tables first. Don't read the text. The figures and the tables should allow you to think about what the text is going to say. And the figure 1 is one of the key ones in my opinion. It's the consort figure. It has the consort figure. It tells you about the flow of patients. The table 1 is classically the baseline characteristics. The table 2 or the figure 2 have the main results. Table 3 and figure 3 may have some additional results, or they may have some adverse events and safety data. So what do I mean by figure 1? And often this figure 1 sometimes, especially NEJM nowadays, hides it in the supplement. So go find the supplement and look at the figure 1 very carefully. And this is what the consort, which is on the reporting of trials here, figure 1 should be. So there's a box which talks about not just the patients who are enrolled, but those who are assessed for eligibility and excluded. And it's not uncommon, and this number may vary, it's not uncommon for only about 20 to 30% patients who are assessed for eligibility who get randomized. And then you look at, if whoever was eligible and randomized, did they actually get the intervention? Was the allocation complete, or were some people excluded for whatever reason? Look at the reasons for loss to follow-up, and are the numbers roughly equal in both groups? It's not unusual to have some loss to follow-up, but if one group has more loss to follow-up than the other one, that's a red flag again for seeing what is going on. And make sure that everyone who was randomized was actually included in the analysis. That's like an intention to treat analysis. Sometimes, people who get lost to follow-up and this and that, you exclude a lot of people, and that's a per protocol analysis, and that's usually, it could be biased. Not always, but it could be biased, so you have to keep that in mind. Some examples of figure 1. So for example, this is a figure 1 from the START AKI. As it shows here, this was figure S2. So NEJM had hidden this in the supplement. Now, START AKI was a wonderful trial. We were a site for START AKI. The results are nice, but you can always still get something from the figure 1. So what you see here, for example, is they started off with 23,728 patients, but about 11,000 patients were excluded because even though they met the inclusion criteria, because something else, there were eligibility reasons. So potassium was more than 5.5, bicarbonate was less than 15, so on and so forth. And out of the 11,000 patients left, 11,800, about 9,000 patients were again excluded because the nephrologist or the intensivist thought that you could not delay dialysis. This patient had to have dialysis now, or you could not do dialysis now. They were going to recover or something like that. So overall, what you see here is that, and about 3 to 4% patients were lost to follow, which is not at all unusual. 96, 97% is pretty good for an RCT to get in. But out of the 24,000 eligible patients, only about 3,000 were randomized, right? So that's a very small proportion who were randomized. So the lesson here is not that the trial results are not true. It's just that you cannot apply the results to any patient who has AKI in the ICU setting. So every critically ill patient who has got AKI doesn't mean you should apply START AKI, right? If their potassium is more than 5.5, if their bicarb is less than 15, or their eGFR was less than 20 to begin with, then these results don't necessarily apply. So you have to kind of think, hey, should I be applying the START AKI results to this patient or something else? This applies most to generalizability rather than to the internal validity of the trial. This is another one, the landmark trial from Japan. This was lanthanum in chronic kidney disease. So they had about 2,400 patients, and they excluded very, very few. Almost all of them were randomized, which tells you that something is very interesting, is that, so again, of course, they had 3 to 4% loss to follow-up, but most patients who are eligible were randomized. And this may have to do something with the Japanese culture that, if you ask patients, mostly say yes. I don't know what is going on, but that's a very unusual experience to get in most of the countries. What about this European trial called LUST? So this was a lung ultrasound in hemodialysis. What's missing here is that you don't even have the number of patients who are screened or eligible. So we just don't know. That data is not available. So, how many patients were screened to get these 363 patients? We don't know. and about 10% were lost to follow-up, which is kind of highish for a dialysis population where patients are not going anywhere. You know what happens to them; they are on dialysis. So despite that, about 10% were lost to follow-up, and about 3% were withdrawn. So after being randomized, after being consented, after being found to be eligible, about 3% patients, the investigators said, I don't want them to be in this trial, in both groups. So that's kind of strange things which are not completely explained in this analysis. 30% patients died. Now that may seem high, but as nephrologist, that's not at all unusual for a dialysis patient trial. Over any length of period of time, you will see that this will happen in any dialysis trial. So, for all these reasons, and I've taken just some examples. Figure 1, I think, is the most important. It tells you about generalizability. It gives you some idea about the event rate already. It tells you about loss to follow-up, especially if it's asymmetrical, and so much more. And when you see these kind of things, when you see asymmetry, when you see some concerns, then you make sure you look at the tables more carefully for those specific aspects. Again, going back and forth is completely acceptable. Now, what do I mean by table 1? This is one of the most important tables, not the results, not the outcomes. Table 1 is really important, but, do not look at it, do not look at the intervention group and the control group and say, oh, they are well matched, or they are balanced, or they are comparable. That's not the purpose of a randomized control trial, and the p-values do not tell you whether this randomization succeeded. It was a randomized trial, you have to take the author's word for it, that it was a randomized trial, right? Unless something else is a huge red flag. This is, a quote from Rajneesh Mehrotra, who is the CJSN editor-in-chief, and now to incoming JSN senior editor-in-chief, is that they don't even accept p-values for trials in that journal, in CJSN and many other good journals. So the purpose of a p-value, when you do a p-value, you're thinking of a statistical hypothesis. So what is your hypothesis here? Is it that this was not an RCT? How can that be the hypothesis of an RCT? And what happens is if you've got a small study, with 50 patients each, even if there is some imbalance, the p-value will not be significant because it's not powered to do that kind of a test. And if you've got a very large study with 10,000 patients in intervention and 10,000 in control, and you're looking at 20 variables, by chance, some of this will be different, right? The p-value will be significant just by chance. And that does not mean that randomization did not work. So the purpose of randomization is not to have two exactly similar two groups. Now at this point you will say, hey, Swapnil, what's going on? This is a randomized control trial. If one group is different than the other, then how can you make an assessment of whether the intervention worked or not? Well, the purpose of randomization is to distribute the covariates randomly and not to selectively bias by having older people in the control and younger people in the intervention or so on. This should be randomly distributed, the covariates, and that's what, whether it's exactly same or not, it's by random chance that there may be some variation. And randomization does not produce balance, and that balance, the lack of balance does not affect the validity of the analysis. So then, how do you do the analysis if there is some, imbalance in the table 1? Is that what you should be doing is you should be adjusting for baseline covariates, and this is a blog that explains it very nicely from Darren Daly. So it's not about balancing confounders, it's about distributing the covariates by randomly. And what you then do is that you pre-specify in your analysis is that you're going to adjust for those covariates. You kind of say, hey, let's say we are going to adjust for age and sex and baseline GFR and diabetes status and something else, and that's what we are going to adjust for. So even if these important things are a little bit imbalanced, we are going to take care of that in adjustment, and that takes care of any imbalance that is going on. That's the right way to do it. And so the other things that you see in the table 1 is that it tells you about the overall population. So look at it overall, right? Not separate by group, and think about generalizability. Are these like your patients, and compare with other trials of the same intervention? So for example, what do I mean? This is a systematic review by Christos Argyropoulos and Mike Johansson. And this is the table 1 of all the Flozin trials that were done by about 2019. So this doesn't have EMPA-KIDNEY and the later trials, but what you can see here, for example, is if you look at the median follow-up, the typical median follow-up was about 2.5 to 4.2 years or so, except for 2 exceptions. So in the DAPA-HF and EMPEROR reduced, which were the 2 trials in heart failure with reduced ejection fraction, the follow-up period was only 1.5 years. And what was that? Why was that? Why was it so short? It was because these trials were halted early, because unfortunately in a patient population with reduced ejection fraction, you get a lot of events. These patients get hospitalized or they die. or there is some other MACE event very often. So events will accrue very fast compared to a trial which is done in the a less selective population. Look again at the proportion of women. It's about 20 to 30%. Why does it matter? Why should we have about 50% women in every trial? Because there are 50% women in the population. More importantly, flozins, SGLT2 inhibitors, can cause genital mycotic infections. And guess which population has more genital mycotic infections? It's women. So let's say they say, hey, 5% of your patients have genital mycotic infections. Well, in real life, it's likely to be higher because your practice doesn't have 30% women. Your practice probably has 50% women. So take that into account when applying the results to your patient population. The ethnicity, most of these trials are done in the Western world, which are mostly in white populations. The exceptions, of course, were DAPA-CKD, which was about 50% white, and VERTIS, which was, almost completely white at 90%. So again, if you have a suspicion that an intervention has a differential effect by ethnicity or race, or, there may be some social factors that matter or geography that matters, these are important considerations. That's what a table 1 is telling you, more than balance between intervention and control. Going on, look at, for example, the hemoglobin A1C. The hemoglobin A1C in these trials was about 8%. Because they had to have reasonably well controlled glucose. So if your patient has a hemoglobin A1C of 10% or 12%, it's not that you cannot use a flozin, but you are more likely perhaps to see the glycemic side effects related to increased natriuresis, because they have so much glycosuria, they may have natriuresis. You may get more volume contraction, you may get more genital mycotic infections because there is all this sugar coming out into the urine and so on and so forth. So be careful in extrapolation. The duration of diabetes in most of these studies was about 10 years, if not longer, and these were not patients with incident diabetes. Again, doesn't mean you should not use these drugs in incident diabetes, just that you have to be careful while extrapolating these results. And you can see an outlier there in that canvas, which was the trial which reported the more amputations and fractures. A lot of those patients, by chance, had peripheral arterial disease. So keep that in mind when you see some outlier when you're comparing trials. There are many more things, right? I'm just showing some high points about what you should be looking at when you're looking at a table 1. What about subgroup results, right? So what if the overall study result is negative, but it looks like in one subgroup, it seems to work in this one subgroup, or vice versa. When you have a result that is overall positive, the intervention works, spironolactone reduces kidney failure, but then you look at all subgroups, some of those subgroups are negative. Does it mean you should not use spironolactone in those subgroups? Well, a trial is powered for the main outcome in all patients. So what it means, it will be underpowered for subgroups. If you've got 1,000 patients, but not all of them are men. So if you look at men and women, 500, 500 or 800, 200, well, maybe in the 200 women, you may not even have enough power to show that the drug is working. So by chance, the 95% intervals will cross 1. So don't look at that and think that, oh, this drug doesn't work in women. That will be completely wrong. This is like a brilliant example where the drug worked in everything. But this is a flozin, right? Dapagliflozin in chronic kidney disease. This is all of them line up on this side of one. It's a wonderful drug. It works for everybody, but this is an exception. What you're more likely to see something like this, where you see that line, and you can see some subgroups are on this side of the line, but many subgroups cross over. And it doesn't mean that the drug doesn't work in that patient population, right? If you look here, for example, in the region, Europe, North America, Latin America, others, they all cross 1. It only seems to work in Asia. Does that mean you will not use finerenone if you are not in Asia? No, that would be ridiculous. Another example here is that if you look at the SGLT2 inhibitor subgroup, there were about 250 patients who were on an SGLT2 inhibitor, and that in those, this is the kind of a result. But there were only, about 24 events. So 24 events in 250 patients, it doesn't tell you with any degree of confidence whether finerenone works in patients who are on SGLT2 inhibitor or not. And you can see that with the Figaro trial, which came out later, and because by that time flozins had been well accepted, they had about 600 patients who were on flozins, and they got about 60 events. So 60 events, which is way more than 24, they got a sufficient degree of confidence that they could say, hey, these drugs seem to work whether you are on a flozin or not. So that's sort of the key, something to keep in mind, is that you interpret subgroups very, very carefully. And it's okay to ignore them because they're mostly random error and chance, and you can consider them as hypothesis generating at best. The p-values for interaction, some journals will publish them. They're somewhat useful, but you cannot rely on them completely. What about adverse events? So adverse events in trials, table 3 or table 4 sometimes, they may not reflect real life experience. Right? I mentioned genital mycotic infections. With a hemoglobin A1C of 8, you may see different level of genital mycotic infections in 30% women than what you may see in real life, where your hemoglobin A1C may be 9 or 10 or 11 and you may have 50% women. And these are carefully chosen patients, so they are often healthier than your general population or your patient. So you may see less side effects. On the other hand, they may have more careful monitoring. Maybe the potassium level is being checked often, maybe the creatinine is being checked often. So there's more AKI, more hyperkalemia, which may or may not be clinically significant just because there is more diligent monitoring. So it can be a mixed effect. So you have to take that, interpret it accordingly. There is no, simple rule for saying adverse events are more or less. For example, this is again the Fidelio trial in diabetic kidney disease with finerenone, where they said few patients discontinued finerenone due to hyperkalemia. Well, if you drill down into the supplement, what you can see is that there were 120 more patients on potassium binders. At baseline it was 17 and it went up to 307 in the finerenone group and 66 to 184 in the placebo. So overall there were about 120 patients more on finerenone who were on K binders. Why were they on K binders? But there must have been some hyperkalemia, obviously, right? So that's why they were given finerenone. And if you look at the investigator-reported hyperkalemia, it was about 250 patients more. About 32 patients more had serious hyperkalemia. So this is hyperkalemia which is serious enough to go to the intensive care unit or to go into to the hospital or get hospitalized or visit the emergency room. So that again tells you that hyperkalemia was way more important than what the authors are trying to say, that hardly anyone discontinued it. Well, they didn't discontinue it because it was treated medically. Something had to be done. Maybe they got P binders, maybe they went to the hospital and other things were done to fix the potassium. Maybe the ACE inhibitor was stopped, who knows. And that number is more than the number of 20 patients who did not develop end-stage kidney disease, right? So I'm not saying finerenone doesn't work, it works, but there is hyperkalemia that you have to take care of when you are dealing with this drug. So look beyond the the top line adverse effect. Everything is fine. The result that the authors may try to portray. And again, look at the figure 1. So this was a study design where they had an extended run-in and screening period. The purpose of this run-in and screening period was to exclude patients who were at high risk of hyperkalemia. Well, then you should be looking at the figure 1 to see how many were excluded for hyperkalemia. That number is not provided to us. We have no idea how many were excluded because of hyperkalemia. So if you apply this finerenone to your general patient with diabetic kidney disease, maybe they will develop hyperkalemia right away, and those kind of patients were excluded in the trial. So that kind of information would have been useful to have for you to know that, hey, maybe half the patients are going to develop hyperkalemia, so then you will be on the lookout. But if it's 10%, you will be like, it's a much smaller number. But if it's 80% who develop hyperkalemia in the run-in screening period, then you are going to be much more careful and meticulous about measuring potassium. And there's much more to know. There's actual statistical analysis, there are effect estimates, survival curves, there are newer Bayesian and adaptive study designs. That's way more than I can always talk. But the main important thing with how to learn critical appraisal is that it requires a lot of time. You need to practice and you need to learn from others. There is no course that you should take or anything like that, which is going to tell you how to do critical appraisal. A couple of small examples. This was a trial done from Italy on cevilamor versus placebo in patients with CKD who were not on dialysis. And it was about 200 patients, and they showed that not only was there the mortality benefit with cevilamor, but it also lowered the need for dialysis, right? So every patient with CKD should be getting cevilamor because you are less likely to die and less likely to start dialysis. What's the hesitation? Well, what you see in their figure 1 is that they don't even give you any numbers about screened or eligible, but then if patients had a poor quality basal CT scan, they were excluded. But coronary CT was not an outcome, so why were the patients excluded if coronary CT wasn't good? Which makes me think that it was a feasibility study and that coronary CT was an outcome, but then they switched it later on. And if you look at their survival curve for mortality and dialysis inception and you add the numbers, what you can see is that all the patients are included in the mortality as well as the dialysis inception, which means that the patients who died were still included as being at risk for starting dialysis. Now, I don't know about Italy, but in most other countries, if you die, you cannot start them on dialysis. You cannot be at risk for starting dialysis because you're dead. So I'm not sure what kind of statistical package or calculation was used to make up this graph. And if you look at this one, for example, in the first 12 months, there are no events at all. So no one died and no one started on dialysis. This is also very strange. This doesn't happen in real life. Patients start dialysis or die all the time, especially if they have got stage 3 or stage 4 CKD. So it's kind of an immortal time bias that was cooked in, perhaps because of the way things were measured or done. This does not happen in a real RCT. There were other issues, right? The trial protocol was not registered. They call it a pilot trial, in which we usually look at feasibility of enrollment or surrogate outcomes, and they report clinical efficacy outcomes. Primary outcome was mortality, but death after dialysis initiation. So they said if you start a dialysis, we are not going to count if you die or you don't die. Although they were following up with those patients. That's like, oh, why? Your primary outcome was not dialysis; it was mortality. And patients who did not have coronary artery calcium data were excluded. There was another study they did, which was published a year later, in patients who had an incident hemodialysis. Again, similar thing: sevelamer versus calcium carbonate. And what they showed here is that their primary outcome was not mortality. It wasn't cardiovascular mortality. It was cardiovascular mortality due to cardiac arrhythmias. A very, very strange, unique primary outcome, which I've never seen again in a dialysis study. And you're not talking about a drug which is an antiarrhythmic, right? This is sevelamer. And the relative risk was 0.06. So there was a 94% relative risk reduction in death due to cardiac arrhythmia. So if you give sevelamer, you're not going to have any arrhythmia almost, right? You are going to be immune to getting any arrhythmias. Wonderful result. But actually, if you look at the clinical trials, and this was done in a letter to the editor, is that they changed. After the paper was submitted to AJKD, they went back and they changed the outcome from death to cardiac arrhythmia as a death, and they all switched it, perhaps because they saw the results and they said, oh, let's change what we are trying to do. So clinical trials registry are also a useful tool to look for history of changes. And genuine fraud is hard to detect, right? This was in the nephrology field. So this was a Canadian researcher who looked at bone stuff, and the studies that she published in JAMA and other journals were actually retracted. This is unusual, and if you read what is covered in the retraction watch, they actually found evidence that she looked at patient records, she changed computer files, and she went into the freezer and damaged some samples so that the audit couldn't be done properly. She was actually let go from the university for that reason. But if you look at the KDIGO guidelines, they have this guideline saying you should do bone mineral densitometry in patients with CKD. What does it rely upon? It relies on this study, which was authored by Dr. Jamal, which has actually been retracted. And if you look at all the KDIGO CKD MBD guidelines, they have about 7 direct citations to her work which support 3 recommendations. They're still there. Paper's been retracted, the guidelines haven't changed, right? So, in my opinion, this topic is terrible. If you look at the mineral bone disease and chronic kidney disease, it's an easy topic to criticize. It's like shooting fish in a barrel, because there is observational literature with tons of confounding and selection bias, and even the trials are like that DIORIO trial I'm showing, which is terrible, right? You can easily poke holes in that. These are a couple of blogs that I've written if you're more interested in the topic, which goes into it in a more fun and entertaining way. There's always more, right? I do mostly hypertension, and a few years ago this came on BBC and CNN saying, you should change the time of day, right? This one simple thing reduces your risk of dying of 45%, and many other outcomes. This was published in a really premier journal, the European Heart Journal, in 2019. Now, these are the guys who got a Nobel Prize for circadian rhythm, and circadian rhythm is really important. There is no question. Nocturnal dipping is very important, and if there is no nocturnal dipping, we know that with nocturnal hypertension, the risk is about 1.4, 1.5, so about 40 to 50% higher risk of having cardiovascular outcomes. Now, what that means is if you take away that nocturnal hypertension, you should get that much of a reciprocal improvement, which will be about 0.67. On the other hand, what these authors found was like 0.55, which is even more than what. So the benefit from giving pills at night was more than the harm that is caused by nocturnal hypertension, which does not make any sense. And the non-dipping pattern is seen for various reasons, right? Maybe a patient has obstructive sleep apnea, maybe they have CKD and volume overload, maybe they have increased sympathetic activity, maybe they have diabetes and some other sleep disorders. So it's a complex phenotype, right? If you just take amlodipine at night, how is it going to fix that sleep apnea or that increased sympathetic activity or the patient's volume overload? It's not going to fix it. So how can it reverse this phenotype just taking the pills at night? And this is sort of a meta-analysis which looked at time of day use and outcomes. And what this shows that, yes, it does matter what time of the day you take a drug if it's a short-acting drug. So in hypertension, this matters for hydralazine or captopril, which are short-acting drugs which no one should be using. In the modern era, we use longer-acting drugs like say amlodipine or telmisartan or perindopril. And for that, time of day should not matter whether you take in the morning or afternoon or night. If you look at the figure 1 for this HYGEA trial, what you see is that, there was zero loss to follow-up, like not even 1% or 2% loss, right? This is bigger than the Japanese trial where I showed most patients were enrolled. Like no one was lost to follow-up for a single center trial, which is like wonderful, 20,000 patients. We should learn from them how to conduct trials and not have patients lost to follow-up. Now what they show here is that not only was there a decrease in cardiovascular death, so 310 patients, but also overall death, which is 957. Now if you look at those numbers, if overall deaths were 957 and 310 were cardiovascular deaths, that means about 650 were non-cardiovascular deaths, which lets you, look back at the numbers and calculate that even for non-cardiovascular deaths, the hazard ratio would be about 0.6. Now, what do I mean by non-cardiovascular deaths, right? So, non-cardiovascular deaths usually refers to death because of cancer, because of infections, because of trauma. So, not only does giving blood pressure pills at night reduce your death from heart attacks, but it also reduces your death from cancer. So, you give amlodipine at night and your patient will suddenly not die because of cancer or they will not have an accident, which is again wonderful if you believe it. And not only that, it reduces uric acid. Giving perindopril at night will reduce will increase your HDL cholesterol, reduce your LDL cholesterol, all sorts of magical things start happening. And if you look at adverse effects, right, the adherence was perfect. This is all they show you. There is no table of adverse events. And what you would expect is, that adherence would not be the same. What you see this is a study from the BMJ, which shows that when you take drugs in the morning, then that has the best adherence. If you take drugs in the evening, that has about 5 to 10% lower adherence, which is common. Most people take their pills in the morning. To ask them to take their pills at the night, the adherence is going to drop. However, in Spain, in HYGEA, it was the opposite, is that patients were wonderful. They took their drugs perfectly. And you normally, if you have any intervention which lowers blood pressure, you are more likely to get adverse effects related to hypotension. So if you are giving pills at night and you believe that it's going to lower the blood pressure at night, you should have lower blood pressure at night, which will do some other bad things. For example, there is subendocardial ischemia because of the hypotension. Maybe there will be low blood pressure in your eyes, leading to central retinal artery occlusion. Now forget about having a higher risk of side effects. They actually report that the risk of those side effects was lower by giving blood pressure pills at night, which is amazing, right? This is just amazing. Now you may think, Swapnil doesn't believe in any studies and he's poking holes in that. Well, this was the TIME trial done out of UK, which was published last year. Very similar thing, looking at morning versus evening bedtime dosing of blood pressure pills, and what they showed is that there was exactly no difference. This was much larger, way more rigorous, and this is way more believable data that it doesn't matter whether you take pills in the morning or night. So my suggestions on critical appraisal is that you need to have a very antagonistic frame of mind. Usually only one author, possibly an editor, and 2 reviewers have read the paper carefully. So don't believe that because it's published, a lot of people have read it. Often no one will have read it, just the author and one or 2 reviewers who may have missed the mistakes. Try to find flaws. You read the supplement, pore over figures and tables, and do not read the introduction or the discussion. Now, even if there are some flaws, it may be that the study is still acceptable, right? Even if I can poke holes, doesn't mean you have to throw out the baby with the bathwater. It may still mean that it's still, you should still practice the change that the trial is showing, except with some caveats about say generalizability or what have you, or look for more adverse events than what you would see in the trial. And this is like a famous paper from J.P. Anadis from Stanford, who talked about, why most published research findings are false. And this statement is in fact very, very true by papers from the same author who has published a bunch of garbage during COVID. So, just some Q&As, and I'm not asking you these questions, but, the most important steps I hope you have learned in learning critical appraisal is to read every paper with a close skeptical eye. You don't need to do a course in stats. You don't need to attend a lecture. You just read every paper very closely, go back and forth and try to understand it to be able to do a proper critical appraisal. There is no correct order for reading a paper. Go back and forth, read methods, read results, go back, read the abstract, read the supplement, then read the results. It's completely fine. You should not finish understanding the stats before you read the results. And in my opinion, table 1 does not tell you whether randomization worked. Do not look at a subgroup analysis. Do not read the discussion. The figures and tables are the most important aspect. The figure 1 is, I think, the most important figure in the paper, more than the survival analysis or some bar graph of effect size. So with that, I'd like to stop. Thank you for this invitation from Dr. Khanna again. If anyone has any questions, you can contact me on Twitter or Mastodon, or my email is up there. I hope you know about NEFJC, which is a journal club we run on Twitter. If you are not a Twitter or a blog person, we also have a podcast called Freely Filtered. The most important thing, of course, if you want to know more about this, these are some suggestions for people to follow. Perry Wilson from Yale has a really nice blog on a YouTube series if you like watching videos like this. The most important thing, of course, is you should be a flozinator, right? Flozins are the most important drugs we will see in our lifetime. They reduce kidney failure by about 40%, heart failure by 40%, all-cause mortality. Every patient you see in the nephrology clinic, think about, can you, are they candidates to have a SGLT2 inhibitor or a flozin? Thank you.
Thanks to Dr. I'm going to hand it over to our conveners for our next session. Dr. Sanat Phatak, who is a rheumatologist. He's a medicine person from KEM, and he's trained at SGPGI Lucknow and currently working at KEM Pune. And Dr. Smriti Khanna, who is a palliative care physician at Hinduja Hospital, Mumbai. For our next session, which is on how to formulate a research question, can I please request the chairperson, Dr. Hase sir, Dr. Manjunath sir, and Madam, K.S. Mehta Madam, to please chair this session, and to take this session forward, can I please request Dr. Valentin Lobo sir to please come.
पहला आपको ओपन करना
नहीं यही ठीक है
यही
मैं जस्ट एक बार बताता हूँ
You want to announce before that what the format is?
Yeah, I'll do that. Hello, good morning. Welcome to this interactive session. So we've made some slight changes in the format to make it more interactive. So what we'll do is Dr. Lobo will talk about setting the research question. We'll both talk a little bit about methodology first. And then we have some exercises that the audience can participate in and actually make research questions, and then think about how to how the methodology can go as well. And then we can invite our chairperson's opinions as well. So Dr. Lobo, please. Thank you.
So my topic was supposed to be on designing a research study, formulating the question, and it's going to be largely revision for those who I think everyone was here yesterday. 3/4 of what I was to talk has been covered. So what I'm going to do is revise that and only make a few points, which means that you'll be rid of me faster. The additional caveat is I hope Swapnil Hiramat never reads any of my papers. So every day in the clinic, we are forced to ask ourselves questions and take clinical decisions. That's on average day we take, it's said, 2 clinical decisions on every outpatient and about 5 decisions on inpatients. So for instance, everybody yesterday also started with, it's a case that is in front and we want an answer. So 50-year-old diabetic for 8 years, trace protein on dipstick comes with swelling on the feet and a creatinine of 1.8. We could ask ourselves unstructured questions when the patient is in front of, is this diabetic kidney disease? That's an unstructured question. Are there different, what are the differentials? What is the mechanism of raised creatinine without proteinuria? Should I do a kidney biopsy, check the fundus, and should I start an ACE inhibitor? If I make this into a structured question to do a study, I would ask, is a patient without proteinuria or retinopathy likely to have diabetic kidney disease? So what are the chances of that? I want to quantitate the possibility that this patient has diabetic kidney disease. Does that possibility justify my doing a kidney biopsy in the patient? Are there benefits of ACE inhibitors? And if there are, do they outweigh the risk? Now, one thing is that if I could get all these answers to my questions from the literature, then there's no point in deciding a study, in planning a study. So if the literature contains the answers, and Swapnil mentioned that, and the Cochrane reviews or even today the Lancet, they have a short box at the start of an article saying, what does this study add to available information? So that's something that I ought to ask myself before I start planning a study. Am I going to add anything, or is everything, that often happens with theses, that and then when we are, why do you want to do this study? It hasn't been done in India. Well, are Indians different every time? If they are, certainly it's worth doing it. Though the ideas for a study might come from the patients we see, from reading literature, from conference lectures, which might suddenly trigger off an idea. Having got an idea, and at the end, as Sanat said, what we're going to do is, there's a small number only, we're going to distribute some ideas and see if we can, from those ideas, generate a hypothesis, ask a question, and then design a study to answer that question. For instance, this is an example. If we have a hypothesis, remdesivir lowers mortality in COVID-19. So we are trying to prove an association between a remdesivir, a set of patients who received remdesivir, that they have a lower risk of dying compared to placebo or standard of care. To do that, we assume that there is no difference, and we call that a null hypothesis. So null, no difference. That remdesivir and placebo have an equal mortality in COVID-19. And then we try to disprove that null hypothesis within a certain confidence. We want to have some confidence that we should reject that hypothesis, that there is no difference. Having rejected that null hypothesis with 95% confidence, we are left with not one but two alternate hypotheses, as I said yesterday. Remdesivir has less mortality than placebo, or placebo has less mortality than remdesivir. Both are possible, and even today statistical packages like NCSS will throw out the probability of the null for the rejecting the null hypothesis, as well as the probability of each of the other two hypotheses. So here's a set of ideas. So in patients with COVID-19, with ARDS, with cytokine storm, will using a cytokine adsorbing device like Cytosorb lower the risk of dying compared with not using it? In patients whom we dialyze with PERMCATs, would using urokinase instead of heparin or trisodium citrate lower the incidence of catheter dysfunction? As AKI, with patients with AKI and fluid overload have higher mortality, then ultrafiltration with renal replacement therapy will lower the risk of dying, shorten the ventilation period and the ICU stay. Many Indian patients with MHD patients are malnourished, so one-on-one dietary counseling will improve nutrition and quality of life. So these are just some ideas I have thrown in. We then go to the next step, search the literature to determine the need. If the questions that I asked have already been answered in the literature, with of course all the cynicism which Swapnil mentioned, we can look at the literature with that cynicism, and in many places prior to starting a study, it's mandatory in many institutes for the student to do a meta-analysis first. Formulate a research hypothesis. So we refine, add focus, add objectivity, define our hypothesis, design the study to give unbiased results, collect and enter the data, analyze the data, and then either publish it or present it. Yesterday there was a lot of talk on you must even publish case reports. We must even publish small case series because at least they would generate hypothesis for newer studies. So this is something known as, which was not covered till now, and that is the finer criteria for a research study. That is the feasibility, the interest in a study, how novel is it, the novelty, is it ethical? Manish Rathi gave an excellent talk on all the aspects of ethics of the research, and is it relevant either to scientific knowledge, to formulating policy, or to future research. So feasible, that should be adequate number. Dr. Srijit talked about, I would face the same situation. Our hospital does 15 to 20 transplants a year on average. So if I calculated that I would need to study 200 transplant patients in a study, it would take me 10 years and probably I would run out of interest and time before that and I wouldn't complete the study. Technical expertise. If I want to do a study on proteomics in say glomerular diseases, I don't know anything about proteomics. So if I don't have the technical expertise, I either cannot do the study or I need to get in a technical expert to help me. Affordable. There was a huge discussion towards the end of yesterday on grants for research, and what emerged is, yes, the grants, the money is available, we need to be able to apply for it, and one of the things about applying for it is to plan a decent quality study to do it. And is it manageable? Do I have the manpower? Do I have the time? All of these things to do a particular study. Making it interesting. So here are some studies I picked very recently published. So clinical characteristic and outcome of NEL1 associated membranous nephropathy. So today I might find this interesting because on a kidney biopsy I can get an IHC done for NEL1. So I might pick NEL1 membranous nephropathy, and I would therefore like to know if somebody has already described the characteristics and outcome. A novel antibiotic targeting the lipopolysaccharide transporter, Nature of January 24. So we are all interested in antibiotics. We are all faced with antibiotic resistance. So this study would interest me. Ultrafiltration rate and mortality, yes, both of those. Lecanemab in early Alzheimer's disease, not very interesting perhaps to nephrologists unless we have relatives who have Alzheimer's disease, then it might interest. Treatment strategy for rifampicin sensitive, it doesn't interest me. The title itself, we are facing problems in India with rifampicin resistance. So somebody trying to give me a strategy for rifampicin sensitive, I have been doing it for 30 years. Is lactated ringers superior to normal saline? This is an example of what Dr. Nitya talked about yesterday. The authors will make us read this study because they haven't told us the result. They are asking a question in the title, NEJM 2023. We'll have to read the study if we want to know whether it's superior. If the study had been reworded, lactated ringers is superior to normal saline in acute pancreatitis, I would have the answer. I would decide that, okay, I'm going to start using ringer lactate. I'm not going to read the study. Lower mortality in patients treated with hydrocortisone for community interests me. There should be novelty about the study. So here are some studies. Use of interleukin 6 receptor antibodies in the second and third trimester of a retrospective cohort study. Yes, it's novel because usually pregnant patients are excluded from the study. So here's a study that's looking at the safety of a drug which may be required to be given to these patients. 2 dose levels of once weekly fosravuconazole. So a new antifungal drug which you can give once weekly compared with the daily drugs. But this study is coming from Sudan in eumycetoma. So what Swapnil was saying a few minutes ago, it may not be applicable to other fungal infections. It may not be applicable to India. Propulsion system design for the Indonesian semi-high speed train. Well, it's novel because it's something new. And the last one is from 130 novel electronic projects. It's novel because what this author did was, he found that his children were watching too much TV and he couldn't control it because he wasn't at home. So using the Timer IC555, he designed a small circuit which was about 4 by 3 inches in size, placed on the top of the TV, which used to jam the remote, so that they couldn't put on the TV from a particular time from when they returned home from school till when he returned home from work. And then he went on to do a study in which he lent it to his friends and he collected the data, and now he's given us the circuit in this paper. What's the relevance of a study? I treat ANCA-associated vasculitis all the time. So a study like this, rituximab versus cyclophosphamide, is relevant to me when I want to. On the other hand, FOXP3 exon 2 controls Treg stability and autoimmunity. I don't even understand the terms. I don't know what's FOXP3. So that study may not be relevant to me. Effect of dialysis dose and membrane flux, yes, it's relevant. The next one is again not. Genome-wide CRISPR screen identifies phospholipids, KI May 2024. Scramblase 3 in the biological target of mitoprotective drug SS31. I don't know what it means. Global trends of acidity in rainfall and its impact on plants and soil is relevant to everybody, because acid rain and climate change are relevant to all of us, and we ought to be doing. Quantum field theory for spin operator of the photon. I don't again understand what it's saying. Now this is a study, a multinational multi-center study mapping models of, the first author is Nivedita Kamath from St. John's Medical College, Bangalore. Now it would be relevant even to healthcare providers and maybe healthcare policy makers, because what this study does is it talks about kidney supportive care models. Meteorological and traffic effects on air pollutants, maybe, maybe not, Journal of Environmental. Organic amine pesticides in drinking water health risk assessment of the Yangtze River comes from China. Now, unless our rivers are similarly being polluted, and most probably they are polluted by pesticides, then this study would be relevant to us. A detailed study of dwarf galaxies in the core, this Journal of Astrophysics and Astronomy, maybe, maybe not relevant, only if you are interested in that. And then there are 3 more from 130 Novel Electronic Projects, a journal which I read sometimes. The third one is relevant. Simple water level sensor or liquid level detector are the secondary air deaeration chamber of our dialysis machines. You will be seeing on your dialysis machines, you get an alarm, level sensor failure sometimes. So that's because there is a level sensor which is supposed to trigger the air separation pump on the dialysate side of your dialysis machine. So that was relevant to me, and so I read the study. That brings me to the PICOT question. The complete is PICOTES. So yesterday a lot of talk on patient, population, problem, interventions, comparisons, outcomes. Additionally, it includes the time frame for measuring the outcome. Now the time frame is not the study period in which the study was done. So it's not I start a study in 2024 and it is till 2026. It is the time frame. So if I'm measuring 1 year mortality or 30-day mortality, that's the time frame for measuring the outcome. The outcome is mortality and the time frame is either 30 days or 1 year, or if the study. There was a lot of talk on effect size. We didn't exactly talk about effect size, but we saw how it entered into many of the discussions, and then there is the study design. So this is essentially what I'm going to go over fast because it was covered, that researchers use samples to know about populations. What we try to do is to draw a small sample from a population, define the values in the sample and extrapolate that to the population. So just now we have a lot of disgruntled NEET students across the country. So if the government wanted to know what the students feel about NEET, the population is 3 lakh students and it's too large and geographically dispersed. So they might draw a sample of NEET students, get their opinions about the NEET exam and come to know. Quality control. A factory which is making dialyzers or double lumen catheters doesn't test every one of the 10,000 dialyzers that they produce. They draw a sample for quality control and they look at those, they test those, and they give us a specification sheet saying this is how the dialyzer will perform under these conditions. So medical researchers, the commonest one, will take a small sample, give a new drug to that and try to extrapolate that. Opinion and exit polls. So the total number of voters in India is about 100 crore probably. So what the exit polls did was they looked at about 5 lakh and they still got it wrong. So and there were reasons for that, which later were analyzed, that it's more of people who tend to answer internet questions, who tend to use smartphones are the ones who answered the exit polls. Not all. The rural people didn't. So population parameters are precise, but we don't know them. So what's defined as a variable in the population is a parameter and it is fixed. but we don't know that value. Samples estimate the value in a sample and extrapolate that to the population. The estimate will never equal the parameter exactly. There is some margin of error which we try to minimize based on our sample size and effect size, and there are some methods of doing that. So yesterday there was a lot of discussion on sample size. Should we calculate sample size or should we not? There are reasons for that. And the sample size, finally, the sample size that we calculate may be wrong. Here are 3 trials, IVORE, IDEAL-ICU and Euphrates, all of which got it wrong. So in IVORE, what they did was, they were looking at high volume hemofiltration in critically ill patients with AKI. They said the mortality in the control group is 60%. We are going to try to reduce that to 48%, that is a 20% relative risk and a 12% absolute risk with high volume hemofiltration, and they calculate they would need 460 patients to have a 90% power in the study. Now what happened was, at the end of 140 patients, they found that the mortality in the control group was 41%, way below what they had assumed, and that in the test group it was 38%, so the difference was just 3%, and they abandoned this study after 5 years of recruiting 140 patients for futility. IDEAL-ICU did pretty much the same thing, as did COMPACT 1. So how good is our sample to extrapolate the results depends on inclusion and exclusion criteria. The tighter the inclusion criteria, less is the generalizability. So the more inclusion criteria we make, lower is the generalization. If we do a study in patients who are more than 18 years old, it doesn't apply to patients to the pediatric population. It may be true, but this study doesn't tell us that. So these are from IDEAL-ICU. First 48 hours of septic shock developing AKI with at least the failure stage. Another mistake that's often made is inclusion criteria age greater than 18 years, exclusion criteria age less than 18 years. It's not true. An exclusion criteria means this patient would fulfill the inclusion criteria, but for some other reason needs to be excluded. So either he's going to die before 48 hours or he's going to die within 7 days, and our outcome is to be measured at 30 days. So that's the reason the patient is going to be excluded. Not because he should, to fulfill an exclusion criteria, the patient should first fulfill all the inclusion criteria, and therefore they are not to be opposite of each other. And this is what Swapnil was also saying, and this is taken from IDEAL-ICU. 3,500 patients were screened and only 488 ultimately underwent randomization. So this is the difficulty with sample sizes when calculated, and the number that needs to be screened is most of the time much larger. He pointed out it's usually you end up with 20 to 30% getting in. So that was about the patient population. Now the intervention. So we need to define, and what's done these days is that the methods are not dumped, but put into a supplementary appendix, because the editors of a journal will rarely ask us to cut down on methods. They will ask you to cut the results down, reduce the number of tables, etc., or they'll push that also into the supplementary appendix, but they won't ask us to cut down methods, because we need to describe the methods in full, because that determines the validity of the study. Using a faulty methodology is going to give faulty results. So this is from the renal study. Look at how well the authors have. The patients in both groups were treated with CVV-HDF. 1:1 ratio of dialysate and replacement. They used AN69 filters. They've told us which filter they were using, which fluid they were using. The only difference between the intervention and the control group is one received 40 ml per kg per hour and the other 25 ml per kg per hour. How much blood flow they kept, how they removed fluid, everything described in great detail. This is START AKI, which Swapnil was on. Once again, they have told us how they did the randomization, what block size they used, what stratification they did. The only difference is between the intervention and the control group. And then they've said the standard group is not obliged to receive RRT. So very precise, very extensive methodology descriptions are necessary. We need to define all the terms that are used. So this is from my own SLED study. Hypotension during SLED, different people would have different definitions. So I had to define it as drop in mean arterial pressure of 10, or stopping ultrafiltration and need to give a saline bolus, or increasing the noradrenaline dose, or an absolute mean arterial pressure of less than 60. Yesterday Dr. Nitesh showed us a study where Nothing was defined. Everything was you go and read this study. Inotrope score as per so and so study. Vasopressor dependency index as per this description. But most of the time we would describe what we are using. So levels of evidence again was described yesterday. So these are the 5 generally accepted levels of evidence. Sometimes they say there are 3 additional ones. So level 6 is in my series of X cases never published, it was like this. Level 7, I remember in one case, in level 8, this is the way I do it and it's the best. Right. So coming back to the Picote's question, why sample size? Now this is from Harvey Motolsky's book, Intuitive Biostatistics, a non-mathematical approach, a book which I find very useful. What he says is that researchers started with a study in 5 patients in each group, and they looked at a p-value. They plotted sample size on the x-axis and p-value on the y-axis. At the end of 5, the p-value is nearly 1. Then they went on to 10 patients. At the end of 10, it's still the p-value is very high. 15 patients. At 20 patients, the p-value became 0.06. At 25 patients, it became 0.03. 30 patients, it's some 0.02. And then it started to go up again. So at 75, again it was not significant. But this study would not get completed. As soon as they reached here with 25 to 30 patients in each group, they would have probably stopped the study. And that's what happens to all of us. When we were doing the SLED study, with the first analysis after 29 patients, no. 55 patients, oh, it's come. The 95% confidence is less than 1. SLED works. So that's what could happen if we don't a priori decide the sample size, and we decide at that time what sample size we have chosen and why we have chosen it. So this again what Harvey Motolsky says, sample size is the result of a negotiation between the difference, that's the effect size, that we are prepared to accept, the significance level that we have chosen, that's the alpha error, the desired power, so the beta error, and the number of subjects it is possible to enroll. So we have to decide all of those. If you choose a very large sample size, any difference will come statistically significant. So this is the ALLHAT trial. 33,000 patients. At baseline, the systolic blood pressure was 146 plus minus 15. They randomized the patients to chlorthalidone, amlodipine or lisinopril. Now look at 4 years, the systolic blood pressure in the CTD group is 133.9. In the amlodipine group, it is 134.8, and in lisinopril, it's 135.5. So blood pressure lowering in all. So then they did 2-group comparison. So CTD versus amlodipine, lowering is 12.3 versus 11.4 mm. P is equal to 0.002. Can you measure a difference of 0.9 millimeters of mercury, which is the difference between CTD and amlodipine? And for lisinopril, it is about 1.1 millimeters of mercury. And yet everybody who makes chlorthalidone will come and tell us, doctor, chlorthalidone in ALLHAT was shown to be superior to amlodipine and lisinopril. So this is an absurd effect size which is not measurable, and in the Hygieia trial which he was showing, I saw the same thing. The LDL cholesterol, which was statistically significantly different with in that, was 120 versus 118. So a difference of 2, which a laboratory probably cannot pick. You do the same sample twice and it comes. So when you choose large numbers, small differences or small effects start to look significant. So this is what, or the other thing is, as I said, a wrong estimate. So in reverse is early goal-directed therapy. Early goal-directed therapy mortality was 30% versus in the control group it was 46%. Looks great. Absolute risk reduction 16%. Number needed to treat to save 1 additional life, 6 patients. Looks really great. And then 3 much larger studies came out. Process, Promise and Arise, by which time protocols were coming into force all over and they could show no difference. Why? Because here you see the mortality in the control groups, which in reverse study was 46, has fallen to about 15 to 20%. So as results overall get better, it becomes more difficult to show a difference. So this is ideal ICU. Again, what they did was they told us about interim analysis. That they said mortality in the control group will be 55 and in the treatment group early strategy will be 45. So we calculated that this statement is in the NEJM. 5% of patients will drop out. So we will need 864 patients totally to do a study with 80% power and 95% confidence, and 2 interim efficacy analysis were planned at which they would do it. So that brings us to, when we're doing a study, we can plan an interim analysis, because usually the interim analysis that happen for me is that the student's thesis time is up, it's got to be submitted, I've got to do an interim analysis and it has to be written. But interim analysis can provide an estimate to an opportunity to estimate the sample size. So this was done in the Euphrates trial. They started with a planned sample size of 360, then they found the effect size was not as big as what they were had planned, and they estimated the sample size and they terminated the study at 450. An opportunity to modify the study design, an opportunity to stop the trial for efficacy. So the carvedilol in heart failure study, the ethical committee said it's unethical to continue to deprive patients of carvedilol. The results are so good, so they stopped the study. And an option to continue the study as originally planned. So there are some rules. If we go on using the same data and submit it to repeated analysis, we induce, and I think Tukaram showed that yesterday, each time the alpha error increases by 1 minus alpha raised to the number of analysis. That's the formula. So they use very much smaller p-values or alpha for stopping the study at an interim analysis. And there are three methods: Pocock's method, Hay-Bittel-Peto method, and O'Brien-Fleming, which is the commonest used. So this is what IDEAL-ICU did, and you can see their statement here. Assuming mortality would be, that's I've already said that, when they actually did at 488 patients, they had planned for 864, they said among the 477 for whom follow-up data at 90 days were available, it was, instead of being 55 and 45, the difference was only 4%. So P was not significant. They said continuing to spend money in a trial that had a little chance of demonstrating efficacy and was undesirable, and they terminated the study. So this is what Dr. Nitya was mentioning yesterday about p-values. This is the American Statistical Association's 2016 statement. I'm not going to go into it because Tukaram talked in detail. Then there was 95% confidence intervals. I want to demonstrate again I've modified the test given in Harvey Motolsky's book for Indian situations. So here are 10 questions. What I want you to do is, in the next couple of minutes, write down the range where you think the right answer for these questions lies, where you are 95% sure that it is where the range lies. So age of Mahatma Gandhi at his assassination, I have modified Martin Luther King to Mahatma Gandhi. Length of the Brahmaputra river in kilometers, the number of countries in SAARC, number of books in the Rig Veda, the diameter of the earth in kilometers, the year in which Mozart was born, seats in an A320 Airbus.
So sir, you want us to write a range, or you
A
want
range.
us to write
No, not the value. A range where you are 95% certain the true value lies. What I did was I replaced all the American things with Indian ones. Ready? No? A minute more and then I'll show you the answers.
You'll have to tell us what is Mariana Trench.
It's the deepest trench in the Pacific Ocean, the deepest point on Earth.
See, he's given the answer.
Okay. Done. Okay. So these are the answers. So age of, all of us have seen that picture of Mahatma Gandhi as an old man leaning on a stick. So 78, the length of the Brahmaputra river is 2,900 kilometers. 8, entries in SAR, 10 books. The diameter of the earth is 12,800. Mozart was born in 1756. 180 is what? Sits in an Airbus. 645 days is the gestational period of an elephant. The distance from Mumbai to Delhi by road, before the new high expressway comes of course, is 1429, and the depth of the Mariana Trench is 10.9. How many got 9 out of 10?
Range, sir.
Range, exactly. So that is the answer. So if you had picked a range where you were 95% certain, 9 out of 10 should have been correct. But most of the time we are trying to be too precise. So we are trying to get the right answer. Now if the first one, you could have written 10 to 100 and you would have surely got the right answer. But it's of no use. It's useless information because we know that Gandhiji didn't die when he was 10 years old, and we know that hardly anybody lives to 100. So if you said, then you said 50 to 80, you would be much closer. So the 95% confidence interval is something where we want to be 95% certain. The true parameter in the population, we have estimated from a small sample. We're trying to extrapolate and see if we can be 95% certain that our value or that the population value lies within our range. And this, what the exercise tells us, as the author says in the book, is making guesses. We are bad at making guesses. So we need studies for that reason, and we need 95% confidence intervals. Why do we need small 95% confidence? The Olympics are on. So somebody gave me a nice analogy the other day. Imagine you are the captain of the Indian archery team and there is a tiebreaker shootout for the gold medal. Now you have two shooters whom you can select, both of whom have an average score of 9. You know, the archery, the center is 10 and then you have circle. Both have an average score of 9, but one of them, his 9 comes because he shoots between 8.5 and 9.5. The other gets that because he shoots between 7 and he gets 10 some of the time. Whom will you choose? Why? He is more likely to get you that 9 because it's more precise. The other guy could give you 7 or he could give you 10. So if you are a gambler, you would. And incidentally, the science of probability was invented by a French gambler called Du Bois in a book which he wrote called The Laws of Chance. Right. So 95, that was about 95% confidence interval. There was a fair amount of discussion. Whenever we estimate a 95% confidence interval, what we mean is that if the study we did was repeated 100 times over, then 95% of the time, this is the range in which the true value would lie. 5% it will still be wrong. So all these have been looked at. Why we p-value? I'll just go back to the ideas I threw at the start before I end. In patients with COVID-19, the research, I'm trying to make that idea into a research question. What is the P? COVID-19 patients with acute lung injury, either a CORADS more than 20 out of 25 or a Murray lung injury score of more than 2.5 with an IL-6. In my hospital, the IL-6 normal value is 6 to 50. So I'm keeping more than 150, more than 3 times the upper limit of normal. The intervention, 2 6-hour sessions of hemoperfusion with the Cytosop device, 24 hours apart with a blood flow of 100 ml per minute. The control, standard of care with ventilation, remdesivir, dexamethasone and proning as needed. Outcome, 30-day mortality, ICU stay, days of ventilation. Beware of surrogate outcomes. So decrease in IL-6 is a surrogate outcome. And the HICORIS study, which looked at high volume hemofiltration, they showed at the end that 80 ml per kg per hour versus 40 ml, 80 ml reduced the cytokines, but mortality was no different. So I wouldn't like to go to a patient and say, oh, here's a treatment, there are 2 treatments, one costs double the other. There's going to be no difference whether you die either way, but you'll die with lower cytokine levels. So it doesn't make sense to do that. The other thing is composite outcomes. So they say beware of composite outcomes. There was a study called the RITA study, RITA 3, which looked at a composite outcome on cardiovascular of myocardial infarction, death and refractory angina at 3 months, and it was statistically significant. And what they found later was that it was 9.6 versus 14.6%. And why it was driven in that direction by only one of the 3 outcomes. That was the unstable angina. So deaths were the same in both groups. New myocardial infarctions were the same, but the unstable angina was less in the treatment group, and so the composite outcome drove it in one direction. An even worse one was another study on CABG and cariprazine, which they said again, they looked at a composite outcome of deaths and myocardial infarctions. And it looked like, oh, the intervention group is doing better, and then subsequently they found the intervention group had less myocardial infarctions, which was driving it in one direction, but the deaths and strokes were actually significantly higher in the intervention group. So a composite outcome can drive something in one direction by a not so important parameter. Okay, last of all, you can do this with me. Chalo. Through the idea, patients dialyzing with tunnel cuffed catheters using urokinase instead of heparin or trisodium citrate to lower the incidence of poor flows. What's the question now? We're going to put it in P. Manjunath, not you, yeah. Just hemodialysis patients. Dialyzing with tunnel cuff catheters. You want to specify the number of times per week, or will it not make a difference? If you randomize, it may not make a difference. If you don't randomize, the person doing 3 times a week is going to get more handling of the catheter than the person who's doing 2 times a week. So you would have to specify depending on your design. Swapnil pointed out that randomization is expected to ensure a uniform playing field. If you haven't randomized properly, then you don't know whether the groups are comparable. Though of course, he said that's why you don't do p-values if you trust your randomization process. So, patients on 3 times a week with internal jugular TCC. Why? Because femorals are anyway more prone to dysfunction. So I'm going to specify that I'm going to study internal jugular TCCs. I'm not specifying right or left, excluding those planned for transplant in 6 months. Because if I'm trying to measure something which may take tunnel cuff dysfunction may happen at 7 months, 8 months, 1 year. And if the patient gets transplanted, a good many patients get transplanted in 6 months, the study will be useless. So I will exclude those who are likely to be transplanted early. Intervention? Yeah. So the intervention is urokinase. I have to define the amount I am going to use and how I am going to do it. So 5,000 units as catheter after each dialysis, or in the actual study which was done, I can't remember the name, it was done in 2016-17, they did once a week urokinase versus heparin the other 2 times. Comparator? Okay. Outcome?
Measure the amount, like less than 300 mils per minute.
But supposing to start with I was not getting 300.
30% drop in flow rate.
Yeah, a percentage drop or the time to which I cannot use the catheter because it gets blocked. So number of sessions with less than 80%, so Sanath said 70%, time from catheter use to reduction in blood flow, or intervention to salvage the catheter, or abandoning of the catheter. So I could choose any, I'll keep one of these which is the most important to me as my primary outcome, and I'll make the rest as secondary outcomes. Time, so time period. So if I have taken time period on this thing of catheter dysfunction, catheter insertion till 1 year after that. And now the effect size, sorry. Someone should tell me the effect size. What are you prepared to accept? So Sanath said 30%, but that's the outcome. So how much effect are you prepared to accept between urokinase versus heparin? 5% difference, or I'd go and look at the days. So if my catheters are going to dysfunction at 100 days with a standard deviation of 10 days in the control group, and increase to 120 days with a standard deviation of 15 days is what. Now the reason for standard deviation is that many sample size calculators will ask you for not just mean but standard deviation. The reason for that is, again, Harvey Motolsky gives what he says this is a silly example, but it demonstrates how you got to go about it. You ask somebody to go to a room and fetch something from there. If he comes back in 5 minutes versus he comes back in half an hour, when is he more likely to find what you asked him to bring? The longer. So longer is equal to sample size. The more time taken is analogous to the sample size. If you ask him to find a watchmaker screwdriver versus a hockey stick, which is he more likely to pick? The hockey stick. It's larger. So the effect size is analogous to the size of the tool that he's searching for. Bigger the effect size, more likely are you to find it. And if you ask him to search for it in one of these hotel rooms versus the garage at home, when is he more likely to find it? In the garage. Why?
More likely to find it.
Why?
It's such less.
The garage is a big mess. Everything that I don't want is dumped there. So the more tidy your data is, the less variability, the more likely you are to find. So sample size calculators ask therefore for the standard deviation, which is, or the standard error of the mean, which is a measure of the variability of the data. So setting randomized control study, I went to OpenEpi 3.3 and I did this calculation. So what it told me is if I want 95% confidence and 80% power, then 10 patients in each group is good enough to detect this. So 30 patients totally. So then I said, oh, but am I going to spend for urokinase, which is about 850 rupees versus heparin, which is 120 rupees. So let me have more confidence. So I went to 99% confidence and 90% power, and then I got 26 patients in each group, which is still doable. I'll stop over here.
Any comments from the chairpersons? Sir, Madam, Manjunath sir.
Thank you, Dr. Lobo. He has given a very good synopsis. So what I think research question is the Achilles heel of the any research. If there is no question, you should not start with research at all. Other thing, all doctors, they are doing research daily, but I don't know why they are running away from the research. When patient, I always tell my residents, your consult should start with question. Why patient is referred to you? Patient is referred for increased creatinine, patient is referred for proteinuria, patient is referred for hyponatremia. That is, your consult start with with questions. Then you plan, you systematic. I always in interview, I always used to ask for assistant professor, even professor interview, what is the definition of research? But 50% of the people, they were not able to give an exact definition of a research. Means systematic process of answering questions was a definition of a research. So daily what we are doing, we are gathering the history, we are doing a physical examination, we are doing a laboratory investigation, we are analyzing, and then we are coming to a conclusion. We are answering different questions. What is a diagnosis? How this disease occurred? How, what is a treatment? Means what is the intervention? Whether this disease could have been preventive? Whether what is the outcome of the disease? And all our research will depend upon this. So actually we should be doing much more research and every patient is a research subject. That is the, and what Dr. Lobo had said, your research should be applicable to your surrounding and your practice. If it is not going to help, that is no point in doing such research. But what I again say, your research should start with a good question.
Dr. Lobo, your lecture was your experience and interest speaking there, right? I am just pulling further what Dr. Hasse is saying. As Dr. Lobo has put it, doing the studies, we may have certain restrictions because of real doing RCTs, because we may not have the support, but though Dr. Khanna said now we can, but still we may not be full-fledged there. And as Dr. Swapnil has said, many times we cannot directly apply the same thing to us. To give an example, we say if you don't do plasmapheresis to anybody who is anti-GBM, who is on dialysis dependent. But I can show in my own case series, there are 2 have recovered. So, as Dr. Hasse is saying, we have one positive point is our population. We are seeing so many patients daily. Just analyzing that number itself give us a voluminous data which can be applied to our own population because we are genetically different. So Dr. Lobo has given a very extensive and accurate pinpointed research question details, so we can really go a long way. For example, during COVID, we analyzed some 450 patients, right? Even I think Divya's has a 250 of transplant patients. We have so many AKIs coming. My own residents in DNB time did 450 monsoon-related illnesses, and that paper has been cited so often. So we should not say that Indian data is not accepted. Let's do what we have more access to.
Only 2 things, sir. One amazing talk. One regarding when we are calculating sample size, better to go with continuous outcomes rather than categorical outcomes, because in categorical outcomes we are likely to require a larger sample size because chi-square test will be used. In continuous, when we are planning, for example, here what we have done is taking the days and standard deviation. It will help you to reduce the sample size. And second thing is regarding composite outcomes. It becomes a necessity again to reduce the sample size. When they have 2 or 3 outcomes clubbed together, then the sample size required for enrollment will become less. That's the reason most of the trials will be taking composite outcomes. Here it is this place where meta-analysis will help, because meta-analysis will split that composite outcomes into whatever they have used, and those data will be added. So regarding sample size, if you want a lesser sample size, which you think we may be able to get that effect difference between the 2 arms, so then we can use this continuous outcomes as a...
The point about composite outcomes is well taken. In fact, that's absolutely the reason why they are chosen. My only idea was to point out what can be the pitfalls of composite outcome. 2 articles, excellent articles on outcome analysis are in the NEJM by Stuart Pocock and Greg Stone. The primary outcome fails and the primary outcome is positive. They came in successive issues in the NEJM, I think 2016, which are excellent articles on how to see the outcomes in a study.
One initiative going on now, it is SONG initiative, like standardized outcomes in nephrology. There they are defining what outcomes, whenever we are planning a clinical trial or we are looking at even observation data, we should have those standard outcomes. It is, I think 3 graphs they are having, which is one is patient important outcomes, which is most important, which is taken after consultation with the patient. Then it comes to the importance to the clinician. So that way 3 core outcomes they have decided, and whenever we are planning a study, better to look at those SONG core outcomes and include them as one of our outcomes here.
Amazing talk as usual. This is regarding Swapnil's talk. He mentioned that you have to include the number of people you screened before you randomized. So what is that? Why is that?
I think because as he was pointing out that most of the studies, the screening, and I noticed that myself in the end when I read the NEJM, like he showed in START AKI, 23,000 patients were screened to randomize about 3,000, 2,900. In Ideal ICU, which I showed, it was about 488 randomized, some 2,500 screened. I know because I am part of the iptacopan study now that to have recruited 13 patients, 59 have been screened. So screen failures are high. The more rigid the inclusion and exclusion criteria, the more will be the number of screen failures. But so when you have studies, as he said, which either don't show the number screen, or where the ratio of screen to randomize is very small, that 90% of the screen got, then he said that sort of starts, given what the normal practice is, that starts to create a doubt about the conduct of the study. So that was the point he was making. That if either it's not shown or it's almost all over screen got, and he gave one explanation that in Japan, that occurred in Japan, where in Japan perhaps people are much more willing to participate. In the Western world, they are not. Like one of the reasons why Novartis came to India, China, Taiwan, Japan and Brazil for iptacopan is eculizumab is freely available in the West. So when a standard of care is available and the state is paying for it, people are not very keen to go into a drug trial for a new drug. Whereas in these countries where nothing is available, people who are facing either death or lifelong dialysis versus a chance of recoverability with a trial drug, they are much more keen to go on to the trial.
So larger the number of people screened,
Yeah.
it adds value to the
Value.
The criteria for inclusion.
One more problem about this screening means whatever inclusion criteria are put, sometimes they are very rigid. Means patients who are not going to respond, they are excluded. Like erythropoietin trial, iron should be 200. In erythropoietin trial, almost 98% patient they respond. But when it comes to clinical practice, not more than 60% patient will respond. That is the very controlled trial and use of drug. So that's why it is very important to see the screen number, how many screen failure and why they were screen failure.
Sir, I also had one question. Can you explain a little bit about what is the difference between composite, secondary and surrogate outcomes?
So composite outcomes is where we pick more than one outcome, more than one event, because the number of events is small. So as Dr. Manjunath said, that it's say in the cardiovascular trials for instance, or even for that matter a renal trial, I want to say as an outcome doubling of serum creatinine or a doubling of or moving from microalbuminuria to macroalbuminuria, so increase in proteinuria. So either of these events would be taken as an outcome if it occurred. So if I had chosen only doubling of creatinine, maybe I'd have to wait for a very long time. If I chose only an increase in proteinuria, maybe there would be lesser number. When I include both as a single outcome, which becomes a composite outcome, I'm increasing my chances of getting an event. If the number of events are very small, you need a much larger sample size to pick a difference between the two groups. Primary outcome should be, and I had it on the slide but I didn't, should be the most important outcome. So if mortality is an outcome, then it should always be picked. There is a huge, this especially among intensivists, oh no, you know, our patients are all sick, we're not going to choose mortality. But one of the things about mortality is there can't be a doubt. Neither you nor me will dispute whether a patient is dead. We might dispute whether this patient should remain in the ICU or go out of the ICU. The one person might say, oh, we can stop dialysis now, he's good enough. They will no, do one more to make him safer still. So we can have a difference of opinion on that, but we can't have a difference of opinion on whether a patient is alive or dead. So that's one of the good things about choosing mortality. And finally, it's an outcome which matters to everybody. So that's about primary, and anything else can be a secondary outcome. Now if we have, and very often that there's most of the studies we find the primary outcome and 9 or 10 secondary outcomes. So the secondary outcome, when choosing the sample size should be chosen either for the primary outcome because it's the most important one to us, or they say the outcome which requires the largest sample size, because then you will surely get your primary outcome in that, the study will be powered for the primary outcome. Surrogate outcomes are when the primary outcome is something that is very difficult to, or it's going to take a very long time, like mortality in cancer. Maybe you would have to follow the patients for 9 or 10 years before. So what would be used is a PET scan showing complete remission. So no lesions. If you have a PET scan at baseline and at 3 months or at 1 year or at 2 years, you can show there's no lesion in the PET scan. That's a surrogate outcome. The real outcome would obviously be the 5-year survival, 10-year survival, etc., which you wanted to know, and you'd have to do Kaplan-Meier stats for that. But because that's going to take a very long time, because even your recruitment would start say today and you would take about a year to recruit the number, and then you have to follow till the last person reaches the outcome. or 5 to 10 years. So for that reason you choose a surrogate outcome. So surrogate outcomes have their problems, as I said, showing me that the interleukin 6 reduced, but the patient, that is exactly what happened in the CyCoV study. In COVID, when they applied Cytosol to patients on ECMO, COVID and ECMO, the mortality was 19 or 20% in the control group and 70%, 71% in the test group, though the interleukin 6 levels decreased. So that's the danger of surrogate outcomes, that they might not be the most important one.
And just to add one thing, for composite outcomes, certain diseases mandate composite outcomes if they are multisystemic diseases. So for example, in lupus or rheumatoid arthritis, where 10 systems might be involved, it is unfair to say that disease flare is only renal. So then composite outcome, if it includes skin and joints and everything else, then you know that a drug is good or bad for all these things. Disease dependent also.
Thank you for that session, Lobo sir, and if I could please request our chairpersons to continue to remain seated for one more session. Our next session is how to choose a research methodology, and the speakers are going to be Dr. Sanath Phatak and Dr. Smriti Khanna.
What is this?
Oh, wait, he's getting.
Oh. It's from the Zoom. Somebody is talking. You want to mute the... Yeah, just mute the...
I think mute it.
Yeah, that one. The research methodology. Yeah, that.
Yes, yes.
Thank you. So we are going to go to the next step. This is a high-level thing because we've already discussed quite a bit about research methodology even in the preceding lecture. And these are just thoughts because we are going to think about doing our own study and what we should think in clinic or wherever else. So now that you've registered for this research methodology workshop, you're sort of stuck in a problem solving cycle. Now you're in. So Dr. Lobo has been talking about the problem, the first step, that is understanding and how we define it and deciding how to answer it. What we will talk about, both I and Smriti, is to plan the actual study. That is what is essentially research methodology. How to measure what we are measuring, what is the kind of study design that we are taking, how we are recording and how we are collecting are more specific things that we won't be talking about. And then of course the cycle goes on to do things with the data that we collect. We clean it, we manage the data, all important things that we are not really talking about, analysis, and then finally come to a conclusion. These conclusions will probably give you new ideas to go back to the problem. So this is the kind of research cycle that we hope you all go into with a problem. So the main thing that I would say is, if you're doing research, have a love for data. What is data? Like Dr. Hase just said, it is nothing but a systematic record of any quantity, of a particular quantity, of any quantity. It's just a collection of facts, that's it. And this is to differentiate it from just an experience. We tend to think that if I have experienced, it must be true, right? If yesterday we saw that example of very eminent scientists saying, I have taken vitamin C at very high doses, or if somebody in the patient population comes and tells you that my child had a sandwich and now it's giving him a headache. it's an experience. We don't know if it is true or not. It is true for that person, that did happen, but that does not give you too much information. Or you have these things, right? You have both doctors and patients saying this. My patient improved the day I prescribed remdesivir in COVID. Didn't he improve because of remdesivir? We don't know, but that is implied. So we think causally, and we think that experiences are how we get things across. And we want to try and suppress this internal need by a systematic record of a particular quantity. Right, so there's this very interesting book called Dear Data. It's very aesthetic, very pleasurable to see. It's a tale of two friends. One lives in New York and one lives in London, and they are both data artists. That's a new field these days. So what they decided to tell each other is that they would send each other one postcard per week, drawing something on the back of the postcard. That's it.
Mute all.
Mute.
Fellows.
Right, so they're just drawing an experience on the back of the postcard for that one particular week. For example, this 1 week, every time this lady looked at the clock, she put it down. And she put that into various kinds. So if she looked at the clock on purpose to know what time it was, she drew a clear circle. If she just glanced at the clock, she drew a solid point. Because she was bored, she drew one bar. Because she heard somebody saying the the time allowed, she put in a triangle. So basically she's converted a very simple experience, just looking at the clock, it's nothing even fancy, to a collection of records with categorization and labeling. And then look how pretty her postcard looked. So from 7 a.m. to 12 midnight, from Monday to Saturday, she's put down all times that she's looked at the clock. And you can get so much information about this, right? About her day, what she's doing, when she's bored. At 7 p.m. every day she's bored. She just wants to go home. At 12 p.m. every day she's hungry every day. So you get a lot of information out of collecting and recording even very, very simple experiences. And that's essentially what we are willing to, or we want to do. Record experiences. That's essentially what we are doing. And it's essentially what we are doing in studies as well. What are we doing? There's not much difference between her simple postcard looking at the clock and these records of what happened to children and adults hospitalized with COVID-19. Both of them, that lady sitting in New York and the people in 7 or 8 centers across Africa, they've recorded things. Rather than seeing one patient being happy that they did well or being unhappy that they didn't do well, they've recorded things, put it in a particular format and put it out. And basically it gives you the power to go past one experience and to build a corpus of information that the world can use. This is what we are doing with descriptive studies. We are observing phenomena. The phenomenon can be simple, the phenomenon can be complex. There is hardly any hierarchy. Some will be relevant to you, somebody will be relevant to somebody else, but that's essentially what we are doing. We are observing the world. And that's the first goal of studies that we are doing, is we are just describing things. And most of science, maybe even until the 1970s, most epoch-making science has been observing things. Darwin observed that some finches have different shapes of beaks. It's an observation. He's done nothing. He had no hypothesis. Watson and Crick observed that the diffraction patterns of radiographs from these molecules look a certain way. So most epoch-making studies are descriptive, And we have many studies going on like this. The census, outcomes of patients with lupus nephritis, they are descriptive studies and still important. The other goal of studies is what appeals to our causal mind. So we find that we think causally, like that lady who thought that her kid got a headache because of a sandwich. We think causally. If I get an upset stomach, I think it's because I've eaten something the earlier day. It has to be because of something. So, solutions okay to use if IV fluids are not available. These are some important questions that people have solved because they thought of a hypothesis. So, we've been studying these kinds of study designs. I won't be going too much into detail, but essentially within an observation, some of them are descriptive, but some you can use hypothesis testing. Experimental studies, of course, is when you're manipulating something, and meta-analysis is when you're combining all of these to form a bigger level of, or a bigger collection of evidence, right? So what is an inferential methodology? Many kids, MBBS kids tell me, if I ask them why do you want to do research, they have this thing where they want to act like a detective. They say that we want to be like Sherlock Holmes and answer questions. So are we acting like detectives? Are we like Sherlock Holmes? I think we are one step better, because what Sherlock Holmes does is a process called deduction. Deduction is taking a general idea or logic and bringing out particular conclusions from it. So for example, if he sees that someone's trouser is splattered with mud, and if you ride in the left side of a carriage, you are likely to get mud splattered there. He's taking that general idea and telling them that you came in a carriage and you sat on the left. So he's deducing something, right? What we are doing is not this. What we are doing is called induction, which is probably one step higher because we have the conclusions. My 20% of patients with lupus nephritis developed ESRD or whatever else. This is my conclusion, and then we are trying to bring that into a general idea, not the other way around. So we are not, the above one we often use in the clinic in diagnosis and treatment. What we are doing with research is inductive reasoning, so that I have observed certain things, these are my conclusions, and I want to convert them into general ideas, right? So this is what Dr. Lobo also talked about. This is the same kind of flow chart where from the data available to you, you take one particular sample, and the problems here are the problems of measurement. So when you are taking a sample, one wants to think about, is this sample reliable? And what reliability means is that if I do it, or if Smriti does it, or if Dr. Lobo does it, if I have been precise enough, will we take the same kind of sample again and again? So this inter-rater variability of if I do a sample now and if I do a sample 20 years later, will it be the same kind of sample? If there's a huge difference, it's not a reliable sampling method, and then you might have problems in interpreting the results from that kind of sample. Is the sample valid? So are we sampling what we want to measure? Is the other question that we want to answer. From the sample, we make conclusions about the study population, and from the study population, then we make conclusions about the target population. So this is what I said and what Dr. Lobo has described really well with what is inductive reasoning. Right. So, like I said, doing research is asking questions, especially the hypothesis, especially inferential research. No question is important or not important. No question is right or wrong. But it's good to have a look at what kind of questions we are answering. Right? Do people get nervous while speaking to others in a group? Maybe, like looking at me, you're likely to say yes. Does smoking cause cancer? will this glomerulonephritis patient's renal function improve with immunosuppressant? So if you think about it, most questions that we ask are causal. What we are trying to look is, will something lead to something? Is one phenomenon giving rise to another phenomenon? Right? So the first question that one would like to ask yourself is the question scientific? So the science philosopher Karl Popper has a definition, is that a question is scientific when, or a statement is scientific when it can be confirmed with empirical evidence. If you gather evidence and you can confirm that statement, so then that is a scientific statement, right? So let's see by a show of hands. What do you think about these statements? Cold weather increases rates of suicide. Do you think this is scientific or non-scientific? Scientific? Raise your hands. Only Siddharth thinks it's scientific. It is scientific because you can prove this, right? I mean, you can measure the rates of suicide in cold weather. You can measure rates of suicide in warm weather. It is definitely scientific. Eating sour foods increases rheumatoid arthritis pain, swelling. Is it scientific? Yes? Yeah, I mean, it sounds wishy-washy, but it is scientific from Popper's this thing, because you can refute it with empirical evidence. It's, I mean, it doesn't happen, but you can say that no, this doesn't happen. Dogs are better than cats. I mean, it is intuitive that it is true, but some people might disagree. But is it scientific? No. Why?
Personal preference. It's not, you won't be able to prove it.
Exactly. More than this, you don't know what you're measuring. So what is better? So if I want to convert it to a scientific question, I could do something like this. Dogs are better than cats at tracking down smells. So then that becomes a scientific, because you can measure how a dog tracks down smells or whatever else. How about this one? A very classic question, a classic statement. Humans and apes are descended from a common ancestor. This was the exact statement in Darwin's original. Is it scientific? So now maybe it is scientific with the methods available to us today. But at the time it was a non-scientific statement. So when Popper wrote his discourse, it was non-scientific. So I'm glad Darwin didn't listen to this lecture. Otherwise we would have been thinking about creationism. And a new drug A increases the risk of renal impairment? Yeah, that's straightforward. That's a scientific question. So that is the first thing that you would like to think of when you're planning a research study is your questions scientific, because it's really difficult to think about how to prove dogs are better than cats. So you can start thinking about this the next time people talk to you also. My political party is the best. This is not a scientific question or a statement. You can tell them that you can ask them the best at what. Only then can we say if it is true or not. So the next question that you would like to think is, what is the variable? So when, like I said, we are studying change. If something is giving rise to something, then we are studying change in the second something, right? If A is giving rise to B, then we are studying change in B. But we are also studying change in A. So both of these, A and B, are called variables because they change. And because B is influenced by A, that is called dependent. And A is called independent, right? So it's good to think about what in your question or in your statement, what the independent and dependent variable is. So for example, drug A increases the risk of renal impairment. What would be the dependent variable? Kidney function. Yeah, exactly. And the independent variable would be drug A. It is also changing. You can change it. You can give higher doses. You can give lower doses. So independent variable is drug A and dependent is kidney function. Frustration causes aggression. What would be the dependent variable? Yes. So aggressive behavior is dependent. You are trying to ask if frustration is the independent variable that is producing aggressive behavior. Is it worth spending 3 hours on a Sunday morning on a research conference? What is the dependent variable?
How much research you're doing?
Correct. So I have called it long-term utility. is it worth thing, and the independent variable is how I'm spending my time on a Sunday. And what fraction of a lupus patient received mycophenolate? No, this is not an inferential question. This is a descriptive question. So here you would not have independent and dependent variables. So this is the kind of question that we saw, like COVID or like that lady looking at clocks. Right. So the next thing that you would like to ask is, how will I measure my dependent variable? Because that has to be valid, that has to be reliable, like we said. So drug A increases the risk of renal impairment. How would you measure the dependent variable? Yeah, exactly. I mean, I've written creatinine levels, but there might be much better ways. So you want to think about how you're measuring the dependent variable. Frustration causes aggression.
Yes, no answer.
Okay, but how would you measure it?
Some scale?
Yeah, so yeah, maybe like a questionnaire. Are you, how frustrated are you, how aggressive are your behavior, or video camera data, if you're going around slapping people, that thing. Is it worth spending time on a Saturday morning here, Sunday morning here? How would you measure the dependent variable?
Number of publications after 5 years.
Yes. Great. I've exactly written the same thing. Fabulous. That's amazing. So maybe a satisfaction questionnaire. So when you look at measuring the dependent variable, we have to look at reliability. So if 3 people do it, will it be the same? If I take video camera data of aggressive behavior, everyone looking at it, and if you've predefined what aggressive behavior is, everyone looking at it is going to say that yes, this is aggressive behavior. So it has to be reliable. It has to be valid. Validity means that you are measuring the construct you want to measure. So if I want to measure aggression and I have video camera data and all I see is people eating food and I see the amount of movement here and there, we are not measuring aggression per se. So that is the other thing. And the third thing is practicality. Obviously, study for 5 years, number of research papers in 5 years is not going to be a very easy study to do, but a satisfaction questionnaire I can give at the end of the afternoon. So practicality comes into how you measure the dependent variable. Then you think about what kind of study design you want to do. If it's an observational or a correlational study design, or is it an experimental study design, right? There are many similarities in both of these. Both are empirical, that is any evidence that comes from measurement or that comes from observation that can be replicated. Both are replicable, both are objective. So you want to think of the similarity, these two. The only difference between these two is one, that is manipulation. One variable is being manipulated, the independent variable is being manipulated in the experimental design and not in the observational design. That's really the only difference, right? And why is it so important? Why is experimental design have such a high pedestal in scientific life? Again, we come back to the same thing, that we are trying to assess what we want to believe in, that is something causing something, right? If a lady said that this drug gave my child a headache, is it causal? How do you know that the drug gave your child a headache? For example, if the drug gave her child a headache 20 times, then you more and more think that maybe yes, it is possible that it is the drug which is giving a child a headache. So if you had taken records from a hospital or from insurance claims and searched out headache and searched out whatever drug this is and found that both of them correlated, maybe it was a drug for headache, right? So everyone with a headache took the drug. So they would be correlated in that kind of data, but the causation, the temporal causation is opposite. So the time when it occurs, one after the other, is important. This is one way of thinking about causality, that temporal association, the number of this thing. So the second thing is called dose effect. So if you have smaller doses, you get a smaller headache. You have bigger doses, you get a bigger headache. All of these things sort of push your intuition more and more to think about causality. A better thing would have to be to have a control. If drug A gives the kid headache and drug B he's playing about, and this happens again and again and again, then you have a control when both times he's taking the drugs for the same thing, that you at least know that maybe it is not because of anything else that is happening, but actually the drug. And to further that, push that intuition, if you bring in randomization, then you're, like we've talked, we've controlled for all these other possible factors. So that is basically what we are trying to do, is push towards getting better and better at answering the causal question. So the next question that we ask in our thing is, can I manipulate the independent variable? So can I do an experiment here? So drug A increases the risk of renal impairment. Can we manipulate the independent variable? Yes. I mean, you can either give it or not give it. So that's a 0 or 1, or you can manipulate the dose, or you manipulate how long you're giving it for. Frustration causes aggression. Slightly difficult experimentally, right? I mean, you'll have to make some people frustrated, or make some people less frustrated. Slightly difficult. Worth spending my time? Maybe you can have a control group here. Like half the people go to a research workshop, half the people go to Alibag, and then see which one does. So you can manipulate it some ways. So, but you come across many situations in which experimentation is unethical or impractical. So you can try and answer causal questions even with observational research with what are called quasi-experimental techniques. So you mimic randomization. There are some fabulous techniques now, Mendelian randomization, some other things, which I won't be talking about, but essentially what you're trying to do here is mimicking what you would have done if it was an experiment. So for example, even if it's single test, pre and post test group, and you measure and then you treat and then you measure, and the treatment can be a disease. We are just calling it a treatment. The treatment can be something completely different. For example, a COVID infection. So if you have measurements from before and then all of them after a COVID infection you measure again and find that they have muscle pain and all of that, then that is essentially how you've thought about long COVID. We haven't given half people COVID and half people without COVID and say that this is producing it. Or you have something called interrupted time series, where you take measurements and then suddenly there's some event and then you keep taking measurements. So you can compare what happened before the treatment to what happened after the treatment. So this is important in natural phenomena. So there's this group of very influential studies called the Dutch winter hunger studies. So there was a huge famine in Holland. And before that, the size of babies, and after that the size of babies, and then long-term metabolic complications were compared and found that early life malnutrition really produces long-term effects. So these kinds of techniques do help in causal questions, and they are very practical when obviously many times experimentation is not possible. Okay, so these are the steps on how you think about a research question and what methodology. I'm going to ask Smriti to take over. She's going to talk a little bit about qualitative research, and then we'll open it out for the exercises.
Good morning. Far, far away from the land of quantitative research is an island. which I've come to talk about. So if, like me, you did not take maths or did not enjoy maths in school, don't enjoy data crunching, but still want a number of titles on your CV, then I may have the answer for you. So we haven't touched too much upon qualitative research up until now, but the basics are here is that in qualitative research, the aim is to examine how and why certain experiences, certain behaviors or decisions occur, in contrast to what we may measure in what Sanat and everyone else have been speaking about, which is the effectiveness of the intervention. So in effect, we are measuring the experience, the phenomenon, or the behaviors around this. So qualitative research can be used to supplement quantitative data. It can also be used as an initial hypothesis generating process, which can then later on be explored by a quantitative study. And sometimes I have one slide on this, on how it can go hand in hand with quantitative to become a mixed methodology study. Now, what's important in qualitative research is that you are using theory as a basis or as a lens to view whatever it is that you are studying. So there are different research designs that where different theories are underlined, and that is the lens that you are using to examine this, because a lot of this is experience driven. We usually either generate theories out of it or take pre-existing theories and try to fit it with the data that we have. One interesting thing is that you may also find that the research question is changing during the study. It's not that the question will change radically, but you are using the data or the information that you are getting at the study to decide how many more interviews to conduct. Do you need to change your original research question based on the information you have received? So there is a trend now in research about more contextualization, more understanding of real world problems, trying to place diseases in the context, in the culture, in the groups and subgroups that people are in. So just the idea that there is no one real world, I think there are a lot of philosophical, there is structuralism and post-structuralism around this. So the idea that there is no one single world, there are narratives which are different narratives based on the people who are experiencing it. And so that's what qualitative research does. It tries to provide an in-depth understanding of the context in which any problem is situated. So the how and why rather than the when and how, when and what. So experiences, attitudes and behaviors. So this was a study that was recently published, I think last year, which talks about the cultural influences on whether patients do whether patients with CKD do physical activities or not, or what their beliefs are around exercise. And you can get the knowledge that you've generated with this data can then be used to actually create real-time interventions, or interventions which can then maybe actually change these beliefs. It's also, it also makes clinical practice and evidence-based medicine more efficient, more effective, more humane, more centered in human behaviors and human understanding. So trying to understand, say, what are the barriers to reducing sodium intake in patients with CKD? What are some of the support strategies that can be used? And then you actually have basically this is you're going to the well to draw water from it. You are going back to the patient and trying to understand why is it that they aren't able to reduce their sodium intake. And then you use this data to actually then create interventions that will reduce the sodium intake. So how do we collect data in qualitative research? It can be from impartial or as impartial as possible observation. You can conduct interviews, structured, semi-structured. You can have focus groups where groups of people who have some things in common will come together and discuss particular number of questions. You can have surveys with free text where you will invite people to write down or talk about their thoughts and then analyze it. And you can use secondary data which is already present out there. And then coming to the study designs. So these are some of the different study designs which are used. This is the theory that is the lens that guides your qualitative research. So these are some of the most common study designs used. There are actually quite a few more. So ethnography is basically, the basis is in anthropology and understanding the culture of a group of people. And so you understand the worldview of the group under study. So here you will tend to take people of a similar culture. So the previous one which I had shown about the BMJ study would be, say this one would be something like that. Like that may be the lens that you would then use. So that is ethnography. Phenomenology is observing a phenomenon but taking the experience from the person actually experiencing the phenomenon and understanding why they behaved as a result of that. Grounded theory is actually kind of like the opposite. So in phenomenon you are seeing the experience and then making a theory out of it, while in grounded theory you are, grounded theory is the opposite of phenomenology, in which you are observing a study population and actually generating the theory through the observation. So here this is also another of the common study designs that is used. And then we have narrative research. So there are narrative studies, like there is narrative analysis. Narrative research is also very individualized or more towards the person that is experiencing the phenomenon. So focuses on the narrative or the story of the phenomenon or the personal experience. Narrative research will usually, you will find that the data that is generated is very descriptive and a lot of ideas can actually come from the narrative. And this is how you can then generate hypothesis and go forward. This is an example of a mixed method study where you can see that they actually used 3 different questions for each of the methodology. Now, you might think that actually mixed method study is simpler because you are trying to, you will get to do 2 different things together, but in effect it becomes difficult because you have to bring the same academic rigor of a quantitative study and a qualitative study. So in fact the work that you will end up doing is going to be double. And a good mixed method study actually links the quantitative and the qualitative question together. So like in this one, symptom experience in a patient with end-stage renal disease, it is important to first understand the symptom burden. And so knowing how much symptom or what is the symptom burden that a patient is facing, and then how they experience this symptom burden, and then trying to correlate the 2. So here you see that there are actually 3 different research questions that this study is aiming to teach. So this is actually a very ambitious study. So like we have metrics for evaluating how good a quantitative research is, you want to look at the credibility, the transferability, the dependability, the external internal validity, the reliability of the study. There are similar metrics for how to determine the whether a qualitative research is good or not. So credibility is by having multiple points of data collection. So if you are able to use multiple methodologies, like maybe having focus groups as well as surveys together. So this will help ensure more accurate results. And peer examination, which is when more than one study author looks at the data and then comes to conclusion. Qualitative transferability is when there is a detailed description of the process. So like everything else, even in qualitative study, it comes back to methodology where if you are able to in detail describe the process, then someone else can also replicate it. And then dependability and conformability is by an audit trail. So I think that's about what I wanted to discuss in like just a short introduction to qualitative research. I'm going to hand it back to Lobo sir, if you want to discuss the questions again, or
People are there who are delegates for the workshop. How many? One.
We can all participate.
Everyone.
Yes.
So that may be split into two groups. So the idea was that what Sanat talked about and Dr. Smriti talked and what I talked, we'll now give you we'll give each of the groups an idea. You use that idea to create a research question and a study design. So some people from this side can move to this side. And then after that, one spokesperson from each group can come up and give us the picotes of that. So this group here, my idea is that the length of doctor's prescriptions is proportional to the number of MRs who visit. So let's hear how you would have a study. And the second one is here that National Board thinks that basic sciences lectures are very important. So let's have a study to see whether nephrology students perform, how nephrology students perform with basic sciences lectures. So those are just, I've thrown ideas. Maybe 15-20 minutes?
Yeah, 15 minutes.
We have 15 minutes.
Yeah. So it'll be good to write down the steps of your thought, like what your research question is, why you thought of
You
it.
can discuss, huh? You're not
Yeah.
supposed to do it individually.
Yeah, discuss
The group can get
within
together
yourselves.
and
And
one
yeah.
person come up as a spokesperson afterwards
Yeah.
and tell us what the study is.
Yeah, come. or whatever we are calling you. Are you ready?
You can go with what they've done.
What you've
there
done?
There are no right and wrong here.
Yeah, exactly. There's no right and wrong here. But should we call the chairperson?
Yeah,
Okay, apologies in advance if this is. Please don't feel that your 2 days of teaching was completely a waste.
No, as I said, there are no right and wrong answers in this. It's how
we tried our best. So we think, I don't have the exactly framed thing. No, like our thing, but the thoughts that we had. So we thought that we will choose one center and we'll choose a randomized control trial. And so just for.
Can you tell us the question first?
That's what I'm saying. So I don't have it. So if I can think. Okay, the question was the correlation. So is there a correlation between the number of MRs visiting a doctor and the length of the prescription? So this was the question. We thought we'll take Tata Memorial Hospital as a center. It's a large hospital. And we'll focus on, in terms of inclusion criteria, we'll focus on the medical oncology department and exclude residents. And then again, as an inclusion, we'll just include solid state tumors. So these were some of the things which we thought might confound the effect.
Okay,
Maybe.
so now what happened? The starting part is good. You've chosen one center where it is possible to perhaps enforce things well. You've chosen one department because there could be variability
Across.
between a surgeon's prescription and a physician's prescription. So again, very good. So good inclusions. But then why do you think the tumor type?
We had no oncologist in the team, but we just thought that maybe hemat and solid state tumors might have different.
Maybe. So that's something.
Or maybe, so we also considered that maybe randomization will take care of.
So randomization usually may take care of any control.
So maybe, that we can exclude. In terms of intervention, the intervention is the exposure to the number of visits. This will be a manipulation. So we will divide the consultants in 3 groups. One group will not be allowed to meet any representative for the next 3 months. The second group will be allowed to meet between 1 to 5 representatives in a week, per week for the next 3 months. And the third group will be forced to meet 6 or more representatives.
So this is the problem with using a randomized control design for this particular study. One, you're trying to not have any restriction. Okay, so they might meet them outside the hospital.
Yeah.
So a randomized control trial is not perhaps the best method to tackle this particular one. You could, but there could be problems with it just like this.
Right.
So, and one, you're forcing them. So if you force me to, someone like me, when I see 10 medical reps outside, I run away from the back door. Because all these guys are going to tell me the same thing they all told me last week.
Yeah.
So
maybe
forcing somebody to meet is difficult again, and trying to prevent it completely is difficult because medical reps are resourceful, they'll meet them outside. So this is a joke, a sort of a humorous study, but still it outlines some of the difficulties that can occur with trying a randomized control design in certain situations. So maybe one would not use a randomized control, would let this go, and then there are methods of adjusting for confounders. Regression analysis is one of the methods that is used statistically. So we could do it even in a non-random.
Yeah, one option was to look at.
So you got the intervention fine, though it's the number of visits of a medical rep to a particular.
Yeah. So maybe have a policy where you record the visits and then look at the data of all the doctors, compare their prescription length and number of visits, and then do the retrospective.
So what's the comparator group here?
So the outcome is the length of I mean the average length of prescription in different groups.
Average number of drugs in
Yeah.
the different groups. So you would calculate a mean difference between means, some difference between median length,
Yeah.
depending on what type of data it is, parametric or non-parametric. So that's the outcome.
Right.
The
The time frame is, we thought 3 months might be a useful time frame. Yeah.
Effect size?
Okay, we didn't get to that. I
So
think.
for that, so to choose the effect size, maybe at baseline you'd look at what is the
Correct,
baseline
yeah.
length of prescription.
Yeah. But in just terms
10
of
drugs
percentage.
plus minus 2,
Yeah.
etc.
Yeah. I think 20% in terms of percentage.
So from 10 down to 8.
Yeah.
So when you we talk about a percentage, but as Dr. Manjunath also made the point, this is quantitative data. So we won't try to look for, we won't make it binary by saying reduction of 20% or
Right,
not reduction.
yeah.
We have average length of prescription with standard deviation, which we can use
Yeah.
and calculate the
P-value.
t-test for
Yeah.
difference between means or a Mann-Whitney, or sorry, it will be a
Chi-
Wilcoxon sign rank. No, Chi is for qualitative data. So Wilcoxon sign rank test, because you are having before and after. So one of these, or Mann-Whitney if it's 2 different groups. And study design we already went
Yeah.
on. Good.
Thank you.
These guys have an edge because everything has been discussed.
They have a different topic.
We allow them to. Yeah, it's a different topic.
So we got a topic of
Spokesperson.
his handwriting.
Go ahead.
So basic sciences training. Basic sciences training. How will it affect the knowledge of nephrology students on basic sciences?
Yeah, but that's
That was the theme.
okay.
So
but you modified the question.
Yes, sir.
Because National Board thinks that everybody should get, all super specialities
Yes, sir.
should get basic science. And they are talking about their performance in their subspecialty. But
Sir.
they're still giving them basic sciences.
So
So
our-
their idea doesn't seem to be to increase your knowledge only of basic science, but okay. Go
So our null hypothesis is that basic sciences training will
Will have no impact.
on existing knowledge of basic sciences amongst nephrologists. That is the null hypothesis. And participants we have taken all nephrology students doing DM, DNB or any sorts of fellowships in hospitals of Mumbai. And our intervention is basic sciences training in the form of lecture, tutorial or any class for a period of 2 hours per week for 3 months over and above the existing training which is being in practice. The comparators we have, we'll plan a RCT, so we'll have an intervention arm and a comparator arm.
This will become a cluster RCT.
Yes, sir.
Because you'll randomize the
Multicentric,
hospitals
yes, sir.
rather than the individual student.
Yes, sir.
You can't in the same hospital have 2
Yes,
students
sir.
attending
Yes, sir.
and the others not.
Yes, sir.
So this will become cluster.
So our comparator arm will be the students in which only the existing form of teaching will continue, and in the intervention arm we'll do this extra teaching for the students in both, and we'll randomize equally amongst DNB centers and DM centers, so that difference is also eliminated, bias is also
So you
eliminated.
randomize, that is expected to happen.
Yes, sir. And our outcomes will be measured, primary outcomes in the form of performance in basic sciences during Viva. Second, performance in theory questions
and MCQs.
and or MCQs.
So you will do a special exam for this?
In the exam, we presume that there are some questions on. And our secondary outcomes can be that increase in the number of research papers or articles on basic sciences. Our time will be 6 months. And our effect size will be
6 months may be very, very short.
1 year.
Because 3 months you are giving your intervention, and to expect them to come out with papers in the next 3 months is difficult.
Yes, sir. And our effect size will be increase in performance by more than 20%.
Okay.
And we plan to do
You
a
need a large
cluster RCT.
sample size for
Yes, sir.
that, 20%.
Yes. Yes, sir. Yes, sir. So baseline we'll see from the existing records that how are they performing.
Okay.
And we plan to do a cluster RCT, sir, as you said.
Good. I'll leave it to the chairperson.
If it is a Viva, the same questions have to be asked.
Yeah.
Both
Yeah.
the groups. So the Viva,
That will be confounding, sir.
Same examiner and same set of questions.
So that will be a
special exam.
Yes, sir.
So
measure.
this effect size would it be 20% difference in performance
Yes.
in the non-training and training group, or 20% improvement from their baseline performance?
So we can also do it in the form of a cohort study, in which we take one center, we take only one institute, see their baseline performance, give them training, and then see their performance. So in that case, we can do improvement in their performance by 10%. But if we want to make it more evidence-based, we can do RCT, take 2 institutes, and make it like that.
The thing is that when you do an intervention here, which everybody knows about, automatically your results
Will improve.
You try to compare with the baseline.
Yes, sir.
And of course, you can't blind. None of these studies
Yeah.
can be blinded. Nobody can be blinded in these studies.
Yes. What we hear, we forget. What we see, we remember. And what we do, that we understand. Means first MBBS, second MBBS, and residency. So why residency is compulsory at the postgraduate level? Because they are going to see themselves, they are going to apply their knowledge, they are going to understand. So for research methodology, what would be the ideal teaching learning method is this first didactic lecture. After didactic lecture, there should be a group discussion, and they will do and they will understand. Otherwise it is very difficult, and this is a good idea to introduce these problems and then solve the problems, and then they will understand it better. And the study design, that is very well covered by everything. It will depend upon what questions you ask. Means like diagnosis or treatment. Treatment is means intervention. So that will be a randomized control trial. Prognosis, outcome of the disease. It may be a cohort study or the comparing. That designs will depend upon what questions, what is the diagnosis, what are the risk factors, that is cohort study and other things. So it is very important again to start your research with the question.
Just one remark and 2 questions. Remark is whether, for brainstem death diagnosis, now they are starting then sensitizing at MBBS level. I think something like that should be started for this, for students to be really very active in the later part. 2 questions to presenters for me. When you say effect size, 20%, 50%, how do you come to that figure? Is it your assumption or you do the... And number 2, for case series, what is the effective number to accept the case series? I mean, number of cases.
Yeah. So, as far as the first question is, effect sizes are chosen on three things. One is what baseline is known, or what you know about the control group. If there is world literature, then of course we choose from the literature, provided the population that we are going to study is similar to what is available. If not, then what is present in the unit which is planning to do it. A pilot study can be run to know what is the baseline, and then how much effect size we are prepared to. As I said, it's a negotiation between how large a sample we are going to be able to study, and what if we choose to, what mostly happens is, in order to get the sample size down, a big effect size is chosen, and then at the end of it you don't get that effect size, then it doesn't come significant, then try to manipulate the data to make it significant. I showed some of the studies where fairly modest sample sizes, like even 5 and 10%, they couldn't achieve. So in ideal ICU, they had aimed for a 10% reduction in mortality from 55 to 40. Now typically, when baseline values are near 50, it is the sample size required is much larger. If the baseline mortality is say 80 or 90, then a 10% is coming significant is much easier to achieve statistically. When you're close to 50, then the sample size required is much larger.
So it's always a negotiation between what we can do and what we are prepared to accept. Now, I might find, as I said, if you have a big enough sample size, then 1 millimeter, 0.9 millimeters of mercury, 2 milligram per deciliter difference in LDL cholesterol can be shown as statistically significant. But does it have any clinical significance? No. So if I can get 20 days more of catheter, tunnel cuff catheter life with urokinase, I might feel it is worthwhile to use it once a week in locking the catheter. If I get 5 days more, then the cost is probably not justified. So what is a clinically acceptable effect size is for the researcher to choose. That this much I am prepared to accept, it is meaningful for me. 0.9 millimeters of mercury difference between two drugs, I can't even measure it in clinical practice. I would want to show that sort of a difference. The second question was?
Case series, what is the number?
There's no number. So even a single case report is accepted by journals. So if you have a case series of 8 cases or 10 cases, as somebody said, as a hypothesis generating study, it would be accepted. If you are looking to show some effect, then like say I'm looking at prevalence, then there are formula for that, for calculating sample size. If I'm saying that the prevalence is so much, and I'm doing a study which is looking at prevalence in this population, in this sample, then there are formula available for choosing the sample size. And the PASS which was mentioned yesterday, power analysis sample size software does that for you.
Very good presentation, both of you. Like 2 things. One, please suggest resources regarding research methodology and qualitative analysis for people who are interested, who can want to read further. These were like, both the talks were quite insightful. And second thing is, in case further methodology, research methodology workshop is planned, I think we should give a bit more time for qualitative research as well, because what happens here is we are taking the patient perspective, what he feels is important. Now finally whatever we do here, whatever we discuss, it should run around, it should be patient centered, patient at the center, and rest everything revolves around that one. So qualitative research will probably give us what they feel are important outcomes. We may feel mortality, they may feel its quality of life. So that it is essential for us to understand what their values and preferences are. We are just assuming here that yes, mortality is important, I want my patient to live longer, but what's the sort of quality of life he has had over that period? So I think probably here we'll get those answers. Those areas also have to be looked, especially with nephrology aspect. So these are 2 things. Thank you.
Thank you to the chairpersons and speakers for that excellent session. For paucity of time, we are skipping the tea break. If anybody wants to go, please get a cup of tea or coffee. Our next session is how to do a literature search and how to choose good keywords. To chair this session, can we please have Alain Mehta sir and Rishi Deshpande sir to take the stage. And to deliver this session, we have Dr. Edwin Fernando sir and Dr. Vaibhav Keskar.
Respected chairpersons, senior members of the faculty and friends. At the outset, let me thank the Mumbai Kidney Foundation and Dr. Umesh Khanna for the kind invitation and this opportunity to participate here, and to Evovital for sponsoring this event. So I shall talk about the effective medical literature search. When this topic was allocated to me and I saw Vaibhav's name, we got into touch with each other and then we planned how we are going to do this session. Thank you, Vaibhav, for setting up a Zoom meeting with me and about a week back, and then we planned how to do it. So I'll start off with some basics of literature search, and then Vaibhav and me would demonstrate online how somebody can do it. So the next half an hour or so, I should highlight to you the importance of a comprehensive literature search, the Boolean operators, the keywords, mesh, databases and resources, etc. Because of Indigo, I missed Vaibhav's talk yesterday. So there are likely to be some overlaps, so kindly pardon me for that. So when I was doing my MD as well as my DM, this is how we used to search the literature. So we used to go to our library and then take a ladder up to the 7th shelf there and pull out one of these books, dust it, you have a lot of sneezing, then bring it down and finally you'll find what you're looking for is actually not there. So it used to be such a laborious procedure, and as Manjunath is mentioning, that particular page somebody would have torn off. So this is how literature search used to be for the youngsters. You know, this looks very ancient. It's almost like a museum. Now things are much better. Now you can sit at home and with the touch of a button, you can search whatever you want. So why do we do a literature search? So what is a literature search? It's an exhaustive search for published information on a subject, conducted systematically using all available bibliographic finding tools, aimed at locating as much existing material on the topic as possible, an important initial step for a serious research project. So you can define it otherwise, a systematic and well-organized search from the already published data to identify a breadth of good quality references on a specific topic. Why do we search the literature? To answer a specific case-related question that we see every day in our practice, to learn more about a medical topic, education. Tomorrow there's a topic going to be discussed by my resident, I would still look it up. To determine the current practice guideline, we have this KDIGO updating now and then. To give the best possible care to patients using evidence-based medicine. And when we are asked to speak in an academic forum, the first thing that we do is to go and look at a literature search. So what is a database? A database is an organized collection of data. Bibliographic databases are searched through many of the same techniques as any other database. Today I'll be focusing on PubMed. These techniques apply to any literature database. So searching a database, different search interfaces do the same thing in slightly different ways. A good search interface should provide ability to search for a specific item and ability to search for related items to a known item, ability to search in a specific field, and ability to combine the search terms using the Boolean logic, and able to retrieve this search in a useful way. So asking the questions, I think this has been addressed, the PICO the format. So the patient, the intervention, the comparison outcomes. Now you have to pass the question. What are the main concepts in your question? A sample question. Does nutrition therapy improve decubitus ulcer in an elderly patient? Now what are the concepts here? One is nutrition therapy. Second is the decubitus or pressure ulcers. The third is the ulcer healing. The fourth is the elderly patient. And of course the treatment efficacy. Now we have to grouping or do grouping or nesting. So what is this? The nesting represents parenthesis, a bracket symbol, is a technique of searching that considers similar concepts indicated by a logical command or expressed in different terms as a single term. For example, you can use fever or febrile, paracetamol or acetaminophen, kidney or renal. So this is called grouping. Then there's something called the truncation. Truncation is a searching technique used in database in which a word ending is replaced by symbols. So a symbol of truncation can be asterisk or a question mark depending on the database. So when we type child, the results of our search will include documents that contain the word child, children, childhood or child care. So everything will be covered. So the objectives here are to formulate a question, understand the basic database structure, use of Boolean logic, use field searching, use of controlled vocabulary, specialty techniques like truncation, and then building your search strategy. So what is this Boolean logic? This is a British mathematician named George Boole who developed an algebraic system of logic that is now widely used in computer and electronic systems, including database searching. A very simple form of Boolean logic is used for searching in most bibliographic databases. So the standard Boolean logic for database uses three relationships among search terms: and, or, not. These are three simple terms. Brevity is in beauty, as Dr. Nithya mentioned yesterday. So these three terms are both simple and powerful. So let us look at some examples. This is and, drugs and cancer. We have all heard about, seen these Venn diagrams when we were in school. So both terms are included in any result. If a record has only one of the two terms, it will not be retrieved. If the record has neither term, it will not be retrieved. And groupings contain terms for different ideas or concepts and can combine the or groupings. For example, heart attack and smoking, diabetes and exercise, cancer and treatment or therapy. Now coming to the Boolean logic or. Now dogs or canines. So only one, not both of the terms are in the results. Or will retrieve the record if both are included. So the or groupings contain terms for the same idea or concept and are usually put in brackets. The term or, and another term, where all terms are different ways of representing the same concept. For example, faculty or teachers or professors. So they all basically mean the same concept. Students or learners or pupils. They again mean the same concept. Now coming to the Boolean logic not. So now drugs, not antibiotics. So it excludes any results containing the term. Records containing both will not be retrieved. The not statements are usually actually put at the end and can contain an or grouping. So students, not dental. Diabetes, not juvenile. So these are examples of using the word not. And you can combine similar terms. Use the Boolean operators to combine different terms, or to combine different terms for the same concept, and to combine different concepts. And not excludes concepts but be used with caution so that you don't exclude relevant items. Now putting them together, identifying the concepts, pass the question, list specific terms for each concept, put the terms for each concept in an or statements within brackets, and then combine or statements with and add not statements at the end. So what is PubMed? PubMed is a free resource. It's maintained by the National Center for Biotechnology Information at the NIH, and publishers of journals can submit their citations to this library and provide access to the full text of articles at journal websites using the link outs. So it contains about 32 million citations in Medline, life science journals and online books. Citations may include link to the full text content from the PubMed Central and publisher websites. It contains all citations from the medical literature back to 1946, and it is updated daily directly from the publishers. It links directly to the home pages of the journals. So where did PubMed come from? The history of PubMed is traced back to the end of the American Civil War, when Dr. John Billings, a field surgeon in the Union Army, after finishing his army service, was offered a job at the Surgeon General's office in 1865 as a librarian. So he took charge of the library. It had about 1,800 books at that time. And he was looking at a graduation thesis on epilepsy. And that is when he found a lot of difficulty initially. So he decided he'll establish a comprehensive medical library for American physicians and to prepare a comprehensive catalog and index of the medical literature. So he was supplemented by the organizational skills of one Dr. Robert Fletcher, who joined the library to pursue the idea of indexing the medical literature. So why use PubMed? So all of us use PubMed. The first thing that we do whenever we have a problem, we go to PubMed. It's the most widely used database. It's free. It's very user friendly. And this is how the home page would look like. Now, if you look at the bottom of the page, there'll be a couple of things here. There are FAQs here and a user guide. And even for somebody who's using it first time, you can actually go through it. It's very user friendly and it guides you about how to go about things. Then there is an advanced search options, clinical queries, citation manager, then the downloads, and then very importantly, this mesh database, which I shall be talking about a little later. The newer version of the PubMed, the newer retrieval features include improved sensors, enhances the synonyms, the plurals, unlimited truncations you can use, and enhanced British American mapping. So the improved best match brings the best results to the top. Now how do I search PubMed? Identify the key concepts of your search and enter the terms or key concepts in the search box. Suggestions will display as you type your search terms, and click search to run this search in PubMed. So now this is something that I ran this morning, COVID-19 vaccine. So you will find about 52,212 results. And here if you looked at the left, you will see the publications, the number of publications that are made. Obviously it was 20, 21, 22 where maximum publications were made. And after 24 you find the publications decreased. Now here you would see the availability as an abstract, free full text for full text, where you can apply these filters and you can filter it out more. In some other topic, if you want to look at literature the last 2 years, it gives you the option of 1 year and 5 years and 10 years. So it comes down later in the left side of the column. So this is a simple search. You're just looking at COVID-19 vaccine. Now how do I search by author? Suppose we know the particular author's name and then you want to look at all his publications. Most of the researchers are working on one particular area. So it's very easy to pick up papers by one particular author. So where we put this person's name either with the initials as it is mentioned here or the entire name format. So this morning I searched Vivekanand Jha, the biggest researcher in our country. And you can see about 571 results. Of course, it may not be very comprehensive, but because there may be some journals where he published and that they are not included in PubMed. And you could see his publications starting from 2002, and you can see the peak is somewhere in 2018, 19, 20. So this is the publications that he has made. So you can put any particular author you want, and then you can retrieve all his publications that are being indexed by PubMed. This depends on the journal it's published. Not all journals are indexed by PubMed. To get indexed on PubMed, there is a process by which it has to be done. For example, our Indian Society of Organ Transplant is not indexed on PubMed as of yet. The Indian Journal of Nephrology is indexed, but the Indian Journal of Transplant is not yet indexed. It has to go through a process before it gets indexed in PubMed. Now, how do I search by journal name? Suppose you know a particular journal and then you know the title abbreviation as given in the Vancouver style or the ISSN number, you could search. Suppose I search Indian Journal of Nephrology. So I get 1747 results. Of course, again, not very comprehensive, but then you can pick up the particular articles in the Indian Journal of Nephrology. So you can see it from 2008 up to 24, you could see the articles there. And of course, the IJN is freely available for our access. Now I have some information such as the author, journal name and the year the article was published. So I want to pick up this particular article. Of course, you could do it on Google, but then we have to just enter in the search box, and PubMed citation sensor will automatically analyze the search for the citation information. For example, this particular journal, Physiology Reviews 2017. So I just type this and I get the article there, role of the immune system in hypertension was the article there. And if you look at the right here, you can see the PubMed Central where this text, full text is available. So if you want this particular article, you just go there and download it there. or it takes you to the journal website from where you can download it. And of course, there is a citation. So you want to cite this again, the citation is here, and you can actually copy the citation. And if you look below this, you will find similar articles on this subject, which is actually very useful. So you pick up a particular topic and you're reading about a particular topic, then you know similar articles will be there, and you can take the entire list out there. And also the articles that have cited this article, that also can be found out in the bottom line. So this gives you a very wide range of coverage and a lot of information that you can get in very quick time. So how can I get the copy of the article? Of course, this is what most students would ask, because sometimes you go into their website and you have to pay so many dollars to get a website. Some of them, of course, the PubMed central citations will be there, and you could just download there. There are a number of articles that are available free. In fact, it will be mentioned very clearly that it is a free article, like for example here. So where you could just go and download this article. Of course, if you have a library, the library could have access to the journal, and some online journals, of course, provide free access. Now this is a search using the Boolean operator. Now we have looked at obesity and kidney. So look at the number of results retrieved, nearly 13,219. And again, you look at the publications. We know a couple of years back we had a World Kidney Day theme on obesity and kidney. So maybe after that there are a number of articles here, and you can see the number of articles is actually rising every year on obesity and kidney disease. And if you have actually read one of these articles, you see this in blue and you see this in purple. So that means you already clicked there and you've read that article. So sometimes you may forget that you have, in the enormous literature that is available, you would have forgotten that you have downloaded this particular article, or you already read it. So it will indicate to you that you have read it earlier. So, and as I mentioned to you, you can look at the list of similar articles. So there are some tricks that you can use. If you use it within quotations, like blood pressure, or if you use it with an asterisks. So you can also use this to search for any phrase that includes a truncated term. So for example, heart, and you put an asterisk. So everything regarding that, including cardiac, will be seen. So then coming to this mesh headings. This mesh is nothing but medical subject headings. Now this is a controlled vocabulary. So every term represents a single concept, and only one term is used for that concept. So for example, there are teachers, faculty, instructors, professors, educators. In a controlled vocabulary, one of these will be chosen to represent a concept. So it could be faculty, dental, faculty, medical, faculty, nursing, etc. So the concept here is people who teach. So the mesh control vocabulary is one of the distinctive features of PubMed, and this imposes uniformity and consistency to the indexing of a biomedical literature. Mesh terms are arranged in a hierarchical categorized manner called the mesh tree structures, and are updated annually. As of today, 30,000 mesh headings are available in PubMed. So here, if you look at the mesh subheading, I shall come to it a little later. So renal cell carcinoma. So you can get it. These are the mesh terms for renal cell carcinoma. So here you can build an option, search option, take diagnosis out, add to the search builder, and then you can add PubMed, search PubMed. So why use the mesh? It increases precision of your search, get articles that are really about your topic, and allows you to use subheadings like therapy, genetics, drug effects, etc. And finds articles regardless of the terminology the author uses. On the other hand, you may not get the latest articles because PubMed database takes a little time to index and label each article. So this is an automatic simple subject search, automatic query translation. So you search PubMed for prostate cancer proteomics. So this includes proteomics, the mesh term on the proteomics in all the fields, and the neoplasms, prostatic neoplasms or prostate and cancer, everything. And this query translation comes this way. Now, once you go to this PubMed, you can actually, there's a drop box here where you can get this mesh terms. Now, let us use this mesh term for malaria. Now, if you go through the entire list, I've only taken a screenshot of 4. There are 14 terms that mesh has listed for malaria. A few years back it was less, now it's about 14. So we have checked the first box here for malaria and the result from the mesh search, and then you go to the display settings and then you put the format of full and 20 items per page and apply. So after clicking on malaria, this display settings, drop down menu, click on full button and then apply. So the record for mesh terms malaria containing the definition, associated subheadings and the list of entry terms and the tree view of malaria of mesh comes here. And highlighted is the definition provided for malaria, and note the subheadings under which malaria can be taken. Now you can tick which one you want, and then for each mesh term, entry terms are also listed along with the references. And now we build this malaria mesh term, and this is included in the PubMed search builder. So we add to the search builder and then you search PubMed once again. So when we include malaria as a mesh term and then look, this morning is the result, 76,766 results we found on malaria mesh terms. And of course, though malaria seems to be a disease that looks like we had conquered, but look at the number of articles that have actually been increasing in the last few years on malaria. Of course, the articles now are on vaccines and other methods of prevention, newer diagnostic methods, etc. So these are the different mesh terms that can be used, and you can set up a filter. These filters are very important. You can look at clinical trial, you can look at an RCT, you can look at the English language, the free full text or the full text published in the last 5 years or 10 years, and then these filters can be applied. So it's not possible to look at 76,000 references. So if you want to look at the last 1 year and you want to look at only RCTs, so you will get only a few out of this. So these filters help you to narrow down your search so that it helps your topic. It is humanly impossible for somebody to go through 76,000 abstracts. So here is one example: carcinoma, renal cell and necrosis and Kaplan-Meier survival. So you will get this combination of articles, and this is the PubMed Advanced Search Builder. So where you add a term to the query box and then enter a search term, and you get this PubMed clinical queries where you can choose what you want, systematic reviews you want, or something on genetics or clinical study categories, etc. So here you can actually look at, you can set your category, whether the scope you want it broad or narrow, the therapy, the kidney tumor and active surveillance, and then you look at, you got 5 results, and then systematic reviews are 5 out of 14, and then if you look at genetics, there are about 2. So you can set your category and emphasize the sensitivity and specificity, whether you want a narrow scope of search or a broad scope of search. So prostate cancer and proteomics category, prognosis, and then narrow it down. So it becomes, what was 82 results becomes only 12 results, and then so it helps you to narrow down your results. And when you are happy with your search, you must save it. So you can save it on what is, either you can just download the abstracts or the citations, keep ticking them, and then you can save it on, you can choose your destination into a file or a clipboard, etc. So this can be saved as a text file on your hard drive. This allows for future editing. Or the clipboard can be chosen to save all your searches. The clipboard will hold the articles on your computer for about 8 hours. At the end, click on the clipboard and collect all your articles. So you can mail it also, if in case you want to look at a mail, or you can set up even alerts if email updates of a new search result on the same topic that can be delivered to your email. And these citations are displayed in rank order from most to least relevant. This is one of the hallmarks of PubMed. But when you search, you will get a better, the most relevant articles on top and the most recent. There also you can actually search by relevance and also by the date of publication. So the latest articles may come in front, or you can search in terms of relevance, where the relevant articles would come first. So something published in 2017 may come first because the relevance is more important, because you ticked on relevance. So then you can you can use all combinations. So you know the author, the year, but you do not know the rest, or you know the year and the words, but you can't remember. You can try it out in this citation, single citation manager, which is under the PubMed tools. So there is a reference manager software where you can actually store all your data. And again, these are the filters that I had mentioned: free full text in English, published in the last 5 years, etc. And you can actually pick up a free version here and then take it from there. So look out for full text articles. Select the papers you want to read to write your manuscript. And not available, then you have to make your way out. There are some pharma companies that are able to provide this educational service where you want a particular article, they can get it for you. So these are the field tags that are used: author, title, text word, date of publication. All this is available in the frequently asked questions section. There are YouTube videos on how to use PubMed. So and once you start using it, it becomes extremely easy. So when you're looking at a bibliographic search, start with clear ideas about what you're looking for. If you do not have a thorough knowledge of the subject, it's good to read recent good reviews that can be helpful. Use electronic tools. PubMed is a very easy way. And how to make your search quick and accurate, you can look at online tutorials, practice it yourself. It's very simple. Identify and use the most appropriate mesh terms, and don't forget to look at the references of the most relevant papers on the topic and the citations also. So if you have a reference manager software, then it will be easy to download. And of course, print only if necessary. We are all worried about the carbon footprints, and we are all talking of green nephrology. So only if necessary, please print, otherwise you can save it. So the 7 steps for an effective PubMed search are: to access PubMed, break your search into component concepts and enter terms for each concept separately. Use advanced search to combine results, display setting to abstract and then apply. Review the abstracts, then relevant citations to the clipboard. For the most relevant citations, click on related articles, sent to clipboard. Repeat till most relevant citations are identified. And of course, you can refine your search using filters like article type, language, publication dates, RCTs, reviews, free texts, or systematic reviews, etc. Now this is about PubMed. This is a Cochrane library. Now this is owned by Cochrane, published by Wiley. This is also a collection of databases. This is a British charitable organization that organizes these medical research findings, and there's a editorial teams that looks into these. It's a unique worldwide organization. It prepares, maintains and promotes the accessibility of systematic reviews of the effects of healthcare interventions. It's a not-for-profit organization, collaborates with organizations free of commercial interests. So these methods are based on the results of studies that meet certain quality criteria, since the most reliable studies will provide the best evidence for making decisions about healthcare. So this Cochrane database of systematic reviews is a leading resource, and it is a peer-reviewed systematic review that is prepared and supervised by the review group. So it goes through a very stringent process where they look into all grey and published in all languages, and then they look at by a structured method. They identify the studies, review for relevance, they do a critical appraisal, and then they extract the data and then they publish. And in this hierarchy, you find that Cochrane and systematic reviews are almost on top of the triangle. So here also you have the similar search strategies. So you can set the limits, all dates or the last 6 months or the last 3 months, whatever. And if you look at this word hypertension, so you get relevant articles, relevant reviews on hypertension. In 2023, the Cochrane database has an impact factor of about 8.8, not that very great, but it's ranked 19th of the 172 journals in the medicine, general and internal category. And it received something like 92,000 sites in 2021 and about 81,000 sites in 2020. The 5-year journal impact factor is 11.95 compared to 2020 when it was only 9.8. So it's a most authoritative and up-to-date source of evidence-based information and can help clinicians make decisions about appropriate and effective healthcare. It brings together in one place research which looks at the effectiveness of different healthcare treatments and interventions. Are they very reliable? About 30% of reviews had major problems, including inappropriate methods and conclusions. Improvement, however, is still possible. So what we started off like this, it's now much better. Today I can sit in front of my laptop and then do a search and get relevant information. So I think as students and young consultants, all of us should be proficient with the use of PubMed. Of course, there are a lot of other databases like Mendeley and all that, a lot of complicated ones which Valley may be knowing. These are there, but I think PubMed is the most user-friendly, and it's been, over the last 15 years I've been using it, found it more and more efficiently doing its work and become more user-friendly. Actually, when I came for this meeting, I thought I was a big faculty invited for this meeting. But after listening to the mind-boggling talks yesterday by Srijit, Manjunath, Valley, Vaibhav and all others, I go back as a very humble delegate. Thank you very much, Kanna sir, for calling me. Now I invite Vaibhav to come over and then help. If somebody has a topic to search, we could do it online and then do it. One of the students can tell us a topic.
The idea was this workshop to involve you all to search actually while we are doing it. So any volunteers, anyone wants to search something?
Please tell your thesis topic.
Yeah, anything. Yes, anyone?
Yes, come on.
I want to know about hypertension in dialysis patients. What is the available data, any RCTs that have been done comparing the efficacy of different drugs?
All right, now let us work together. So you want to understand hypertension in dialysis patients. So tell me the keywords that you have in mind. So ask me a question in PICO format.
So in patients on hemodialysis, whether drug A is better than drug B in controlling hypertension.
Okay, let's go a step back. Hypertension in dialysis patient. What do you want to know? Incidence, causes,
so I want to know
treatment.
About drugs, like RCTs that
Right.
have been done,
Okay.
which compare the efficacy of two different drugs in controlling hypertension in dialysis patients.
Fine. So tell me the. Yeah, go ahead. Go ahead.
So before going into such a specific question, so let us first review the subject. Okay, so let us search for hypertension and dialysis first. Look at some review articles, understand the subject, and then go to your next question of whether A is better or B is better.
Yeah. So so for example, this is you're doing this for a seminar that you are delivering or talk you are delivering, or you want to design your own thesis. So you have to formulate a question, identify the keywords, okay, and have in mind what kind of studies you want to search for. It could be, say, retrospective studies, prospective studies, or it could be actual trials. Okay, so do you want to try how to do it in PubMed?
So I'll type hypertension
Okay.
and hemodialysis.
Is this screen visible on YouTube also?
Yes.
Yes. Okay.
It is.
Okay, I have typed hypertension. What else? And
Hemodialysis.
okay, I search. So I got 17,000 results. Alright, so what PubMed did is it brought out all the articles that contain hypertension as well as hemodialysis. Any article that has either one of them only is excluded. So all of them have hypertension. So look at the example. First is hypertension in patients treated with in-center maintenance hemodialysis, current evidence and future opportunities, a scientific statement. So the most relevant one will appear here. Okay. So now what you have it in mind, first, as Sir said, you want to understand what the previous studies have done, and then in particular you are interested in randomized control trial. So maybe you can save these searches like this, click, and then you can actually save the search. If you log in, you can do that. But before that, let us use filters. Okay. So in filters, if you scroll down, of course you can click any of these. If you click abstracts, you will be able to read abstracts and decide then and there whether this article is of your interest or not. Come down and search for clinical trials, search for meta-analysis, because meta-analysis will be a source where you will get all the RCTs. Someone has done that work before. You don't need to invent the wheel. Click trials and now see. Now your search is narrowed to 1139 results. Okay. So now look at this thing, effect of hemodiafiltration and hemodialysis in mortality in kidney failure. Is this the one you are searching about? No. This article is there just because the subject, the either title, abstract or full text has hypertension and hemodialysis in it. Okay. So even if it is not about treatment of hypertension, so this is giving us irrelevant results. So what should actually be done is to identify keywords, see if they have mesh terms allotted to them, combine all those mesh terms and build your search. Okay, so let us start afresh. Now you guide me how to do it.
So we go down.
Okay.
Explore mesh database.
Okay, excellent.
We type first hypertension.
Oh, so many entries for hypertension. Tell me which one.
Only hypertension.
All right.
And search. We add this to the search builder.
You want to first explore what is there in because if I add to search builder, even incidence of hypertension, hypertension in animals, whatever the subheadings are there will be included. So do you want to choose anything? Drug. Anything else? Therapy as well? Okay. This will be repetition, but you want to see what else is there. Just go through all other subheadings also. Maybe include diet therapy also, because sometimes they may remotely be connected to your search. And then, are we missing anything?
Unfortunately, dialysis mesh term is not.
That would have been very easy. Now tell me. So you think you have covered hypertension. Then I'll type and You can type it here also, or yeah. Hemodialysis. Okay. Okay, now we have renal dialysis, solutions, and okay, so I'll click on this and try and see if there is any relevant subheadings. Adverse effect classification, economics. Is there anything of relevance?
Under entry terms it's there.
Pardon?
Under entry terms it's mentioning it includes hemodialysis as well. Done.
Okay. Huh. So if you don't find any subheadings relevant, you can simply ignore them and add as such to search builder. Okay. So you don't have to compulsorily check the boxes, you add. Okay, so I can change this Boolean operator here, but I don't want to use or, I want to use and. Okay, so I have, once I click on add to search builder, the search builder has added and in after that it has written renal dialysis as mesh term. Okay, so should I click on search? Do you want anything to add? Not. Yes. What do you think about? Not what?
Included this extra hospital dialysis
So these are synonymous these things. Okay.
Not
So what is extracorporeal dialysis?
You do not want peritoneal dialysis.
So there is no peritoneal dialysis term separately. So if you exclude extracorporeal dialysis, you may actually be excluding what you want. Okay. So all hemodialysis sessions are extracorporeal dialysis. That's what. So let's see what happens. Okay, now I have got 1,500 results. So just read couple of them. Real world treatment for hypertension in hemodialysis. Second one is effect of hemodialysis practice guidelines on dialysis indicators, hemodynamic complications among the patients undergoing hemodialysis. Some of them are relevant, some still may not be relevant. So what do? You apply filters. What kind of filters do you want? Trials, meta-analysis, RCTs, okay, is that enough? We can see, we can always change the filters. Now you have 184, this is slightly manageable. Okay, so let's see, pragmatic trial of hospitalization rate in CKD, is it relevant? No. So you just go through all these citations and pick whatever you are interested in. For example, beta-blocker efficacy in intra and interdialytic hypertension patients, a systematic review and meta-analysis. I think this is gold mine. Okay, so this is your starting point. So click on that.
It's gold mine and also a very recent publication, 2020.
Yeah, so probably someone has worked on it. So he must have seen all the literature. Of course, we don't only rely on this, but we get very good starting points here. So now, can you suggest what should I do with this review? Okay, I have saved and now I am just going through this citation. So is there, on this page you can get very good references. So comment in similar articles. Then if you go to the full text, references, cited by, all those are important tabs where you can get the articles you are interested in. Let's see what this tab gives us. So these are the references and show all 29 references. Most probably this list will have the randomized control trials that you are interested in. So this is one way, and then you can click on each one, add to the save this search. Now go down to similar articles. skim through these articles and see if there are randomized control trials about drug A versus drug B. Go to cited by. So any article that has published after this article, which had cited this article, you can get important data in that as well. Scroll it down. Okay, so it has given mesh terms. So see if you have missed anything. So you just use hypertension and hemodialysis. See if you can, use treatment outcomes, renal dialysis. Renal dialysis we have used, and we have used drug therapy. And we just missed probably this important mesh, but otherwise we are good. We don't need to use humans and come down and see if you are missing. I think we have covered this. Okay, so this is a good starting point. You go through these resources and sort articles one by one. Okay, anything else that you want to add, Dr. Edwin?
I'm curious how it chooses similar articles. Because like for example, the first one, I mean, to the eye doesn't have anything to do with this article. So.
Yeah, I agree with you. So ideally what it should do is similar articles are chosen based on keywords in mesh terms. So,
but even relevance, like even with a simple search, how does it choose relevance, or how does it choose what comes first?
So there is this mapping done by PubMed to mesh terms. So if there is a mesh term existing, that will be used as first research. So let us see what PubMed does. Is there a way to find what it does is? Yes. So I'm writing hypertension in hemodialysis patients. I just asked a query. Okay. So I'll clear all the filters. Okay, now I have 14,600. So is there any way I know what PubMed did? Is go to advanced, go here and look at this hypertension hemodialysis patients. Click on that. This is what PubMed did to answer my query. So it first searched I think I typed it wrong, but okay, hypertension, all fields. I did the right thing. Okay. So it searched for hypertension in all fields. It added hypertension. It added after the OR. It added hypertension as mesh terms only. Then hypertension in all fields. Hypertension. All the variations of hypertension, hypertensive, in all fields, and basically mesh terms. And then after this was about hypertension till this time, and after and it started adding dialysis terms. Dialysis in all fields. All fields is title, abstract, and the actual paper. Then it added patients. So look at this thing. If I add patients, so I may get articles which are not relevant to hypertension or hemodialysis. Any paper that has only patients is also included. So I have to be very careful when I type in. About the Boolean operators, if I type in small letters, there is a chance that instead of considering that AND as Boolean operator, PubMed thinks that I have to give articles which have AND in the title and in the abstract. So I may get irrelevant articles also. Probably that is why sometimes we get irrelevant similar articles. Okay. So so this is the way PubMed thinks. So easier one, I think it's easier to understand, is IgA nephropathy treatment. Okay, so I typed in without considering mesh terms, without considering Boolean operators, and there is a good chance that I get relevant articles in first few ones. Current treatment of IgA nephropathy in adults, all this, probably all of them are relevant. So is there any way I can restrict myself to relevant randomized controlled trials? Can we do this exercise? Anyone, any volunteers? How should I start? I want to have, do we have time? 5 minutes, okay, just last thing. Any volunteers? How should we start? Okay, let us see what PubMed has done about this query. So instead of only mesh terms, it has, all other relevant articles also. Any therapy which is mesh subheading. So instead of that, I have to be very specific.
Is there a way to just directly edit on that itself? It has already done a search for us with a lot of search terms.
So if I have done it before, I can get it already.
I'm saying.
You can copy paste that into the.
You can just, is there a way to?
So this search term you can copy paste into the.
Yes, we can do that. For example, I just copy it. Open a new window or even the same window, and I can simply edit it. Yeah. So that is possible. But now if I want to search for IgA nephropathy, I just go to mesh database. I type in IgA just to see if IgA nephropathy is a valid mesh term. Yes, it is. So drop down menu suggested that IgA nephropathy is a valid term. I go in therapy and I add it to search builder. Oh, surgery as well. Yeah, because people use tonsillectomy. So anything else? Rehabilitation. Okay, transplants will be under this. Anything else that you want to add?
Do you want to add mortality also?
Okay, mortality. Anything else?
Prevention and control.
But that will not give me treatment.
It will guide you in the staging for different pathological.
All right, let's see. I add to search builder and then search PubMed. I quoted phrase. All right. Rehabilitation. There is under this subheading there was no article indexed, so that's okay. So I've been given 940 results. So let me restrict to clinical trials. I got 68. This is manageable. So let's start. So effectiveness and safety of corticosteroid therapy in IgA nephropathy. Of course, you can change the way it is sort by relevance, sort by best match, sort by publication date. So this is quite reasonable, most recent.
So here in this list, suppose we come across articles like there was one article on animals, rats, and there's one in pediatric population. We want to remove
Yes, we can do that. Come down, additional filters, and species, humans, age, whatever. Okay, you can do that. Okay, but to start with, I would recommend to keep the scope wide, because it may happen that you missed a very good or important article if we restrict. For example, there are studies where now even children are added to the inclusion criteria. Earlier, every trial would exclude people below 18 years. So now we are coming up with glomerular trials, glomerular disease trials, where even pediatric population is also added. Any recent example of this? Any FSGS trial that included children as well as adults? Okay, homework. Okay, so the point is, do not exclude too many things to start with. As you go ahead, you can do that. So let me uncheck this and go for randomized control trial. Okay. Now see, somehow I am not getting the latest trials.
Maybe you can use the filter for year of publication.
Most recent.
Yeah, so I missed something.
You can just move that slider also on the left from 86.
No, but actually it is sorted out in most recent.
Most recent. Okay. So all right. So let me go back. If I want to save this search, I can click save and create a file, but you have to log in to access this. I can email this, I can send it to someone else. Display option will have summaries or abstracts or PMIDs in it. If you don't want to scroll too many times, you can have 200 at a time, and yeah, like that. So you can modify this search. Alright, I think this is the time we have, and we have to conclude the session. I hope there was some clarity about doing it hands-on. You can keep doing it to get better at it. Thank you. Thanks. Any comments from chairs?
I think Dr. Edwin
I think this was a superb session, good initiation for people who are still not using PubMed routinely. It is something that has to become part of our daily routine when we are working, and like you said at the end, keep doing it to get better at it. And I think we are still evolving, so we are all learning with time how to use it.
I think all has been said, but when Edwin started, I was taken back to 1977-78 when I started on and how we used to climb up and remove and ate a lot of dust. But this of course is now, and what Vaibhav and Edwin have done is taken us to what is current day methodology for getting a good literature search and trying to expand the available data for planning your study. Thank you.
Thank you.
Thank you to both the chairpersons and the speakers. And coming to the last session of our day, a few weeks back, one of my endocrinology colleagues he heard a talk basically how we can use artificial intelligence in our clinical day-to-day practice. And my paths I crossed with Rohan Desai, and I told Rohan, you need to meet Khanna sir, because Khanna sir has been he keeps emphasizing how we can improve our nephrology beyond classroom platforms, and this was probably the best occasion we could hear Rohan speak. So for this session, can I please request Dr. Sanat Phatak, Dr. Siddharth Warrior and Dr. Smriti Khanna to please take the chairs. And I would like to invite Rohan Desai to deliver his talk on how we can use artificial... Yeah, so he is going to give us an idea how do we use AI tools in research, analysis and publishing.
Since Rohan is many things, and since we are not really clear about his CV, I thought he has multiple hats to wear, so he would only introduce himself as to what he does and how he can be an asset. That much I know. He's going to have many more interactions with us. I'm quite hopeful. So Rohan, you will have to tell us something about you and about what you're going to speak.
Thank you, sir. Just set up Zoom screen sharing so that everybody can see. Can people in the room, I mean in the Zoom room, see the screen and hear me? Then I'll start. If you could just put a comment. हाँ स्क्रीन शेयरिंग नहीं वो मैं कर लूँगा अभी ये स्क्रीन दिख रहा है दिस स्क्रीन इज विजिबल नो या परफेक्ट एंड एम आई ऑडिबल ओके
And of course we have YouTube live also going on.
Thank you, sir. Thank you to Dr. Umesh Khanna, sir, for inviting me, and to Dr. Nikhil for introducing me to sir. And yesterday, everyone started with a disclaimer saying they are not a biostatistician. I am not even a nephrologist, and not even an engineer. So, introduction, I don't know, sir. So. Yeah, I was telling Dr. Siddharth that I am a dabbler at best. So tech has been a hobby and passion since childhood. Good marks in 12th standard plus doctor parents equal to an MBBS as an undergrad. So that's what happened. So parents were doctors, got good marks in 12th, so became a doctor. And at some point felt that I love math too much, so went ahead and got a MBA degree, coexisted with engineer friends from then on. So yeah, that's a brief background. I thought before I get into the presentation, I'll just show you like a couple of things that AI is already doing. So what you see on screen is a typical AI tool. This is not something very special or even paid. All of you have access to this. We'll talk more about this. This tool in particular is ChatGPT. It's available as chatgpt.com. And this tool is Claude. Claude is a peer to ChatGPT. So both are what are called as generative AI tools, and we'll talk a lot more about them. But this is, so I took permission from Dr. Srijit yesterday. So I had actually taken a photograph when he was presenting, and so I just uploaded this photograph into Claude, and so I just asked what's happening in this image. Can you explain in detail? So the answer was that this image is a medical research presentation, event details, Sofitel, what's going on, venue, sponsors is ever vital. So this is just, just take a photo, upload, and then I said, no, but I want to understand more about the data in the tables. I didn't want all this peripheral information. Tell me what's happening in this image. And so it says, okay, sample size 266, living recipients 172, deceased recipient 94. I'll jump to the conclusions. So it said living donors tend to be older than deceased donors. There's a gender disparity between living and deceased donors and recipients, and so on. Just proving a point here. So yeah, it's very much here, and it's very easy. And the rest of the session, I was telling Dr. Siddharth, this is almost heretical after what we've had for 2 days. Nothing is undermining the research process, but I'll tell you where we can use AI and where we shouldn't. There was another interesting thing I did. I mean, it's more fun to do these things. So I just asked this question. What's common to IVOR, Ideal ICU, and Euphrates? Sir was talking about it. So it said, I'll need to analyze, and they are all names of clinical trials in intensive care unit settings, all of that. It didn't get the answer immediately. So I said something regarding sample size. it says, thank you for the additional hint. You're right. It says they were all stopped early due to futility. And then specifically, Ivor was stopped after enrolling 140 patients out of a planned 160, and Euphrates was stopped after 450, and so on. So this might make you feel AI is very intelligent, but we'll look at it in the presentation that it's actually as dumb as it is, and being dumb gives it all the power. So I'll explain what I mean by that. So I thought I had to use those two examples to give credence to this. Lenin said that sometimes there are decades where nothing happens, and then sometimes there are weeks when decades happen. In 2022, 2 years back, around 30th November, ChatGPT was launched, and in a couple of weeks, decades happened. So this is a chart which shows how long different popular apps that we know today took to reach 100 million users. 100 million is 10 crore users. Spotify, so Netflix took 10 years, Airbnb, Twitter, Facebook. TikTok took 9 months. ChatGPT took just 2 months to get to 100 million users, and that's just testament to the sort of power that it has brought. In terms of just giving you some quick snapshots of what AI is doing today beyond the fun use cases. So this was, AI versus 5,000 engineers, and it outperformed 5,000 engineers in a coding test. Microsoft has this new AI which needs a 3-second sample of your voice to fully replicate it. It's just a 3-second sample. Then you give it a sentence and it'll speak in your tone, diction, mannerisms, everything. It has cleared the USMLE and the Wharton MBA at the same time. And after clearing, it also correctly diagnosed 87% tumors in 15 minutes compared to 64% in 50 minutes. So yeah, things have started happening. It's better, it's equivalent to dermatologists in identifying skin cancers, better in people of dark skin. It can predict risk of suicide. Ironically, the one edge that we humans had of being human, it's even better than us at that. So it's better than doctors in empathy, and which is so weird. A system is better than us. So yeah, it's this is AI today, so all powerful. I introduced myself. I did my MBBS, then went to do an MBA, moved out. Have been in consulting after that, and for the last 10 years I'm building this platform called Netflix. Just a few terms before we get into the session. So technology. Yeah, sorry. So technology is the thing behind all these tools. So so what we just saw, Claude and ChatGPT, they are tools, and there are many tools. We'll look at least 3-4 tools today, but the technology behind them is the, what you have machine learning, neuro-linguistic processing, LLMs, all of that. We are not interested in that as the scope of this discussion. This is what hardcore researchers and engineers are building. Tools are the applications of these technology. Use cases and prompts are what are most important to us. So once you know that, okay, ChatGPT is a tool, Claude is a tool, but what are the use cases? How do I use them? What do I use them for? And prompts is the language which you will use to get the tool to work for you. So when you had Google, you had search queries. On PubMed, you built queries. On AI, you write prompts. It's just a matter of syntax as such. But yeah, they are called prompts. So, AI has been there for a long time. It's been there since 1950s. It's definitely not a new thing. What is new is generative AI. Generative AI was in the works for the last few years was released in 2022 by OpenAI, the company which built ChatGPT. So generative AI is, it refers to deep learning models, the technology behind them, that can generate very high quality text, images, and other content based on the data they were trained on. Just a definition, good to know. Large language models, so we'll just take 30 seconds to explain how the large language models work. It's essentially an algorithm, so think of it as a software which someone built. And then you train that software on 10,000 pieces of information. So you show it 10,000 photos of a dog and say dog, dog, dog. And then you show 10,000 photos of things which are not dogs. And you say not dog, not dog, not dog. Then when you give it a photo, it will tell you whether it's a dog or not. This is the crux of the training which happens for the large language models. So only that in the case of large language models, as the middle L says, it's language model. So it's trained on, I don't know the number, but like billions and billions of gigabytes of data, which makes it very powerful. And what data is it that it's trained on? This is all possible data that they could scrape on the internet. So this is obviously your entire PubMed. This is everything, but there's also a lot of non-credible data. So they trained it on Instagram content, on Reddit content, on anything, all blogs that were accessible to them. So a lot of books also. So this is what also makes it prone to mistakes, and we'll also see an example of that. So moving on, what is ChatGPT? It's a chatbot. We just saw Claude, but Claude and ChatGPT are the same. So they are chatbots. You go to them, it's a conversational interface. There's a box, you type something inside. There's an answer. So unlike Google, so Google is not conversational. You put a query, it gives you results. You click on the result and you go about your work. With ChatGPT, it's conversational, which means you put a question, it will give you an answer. Then you ask a further question, it understands that the context of the first question. You can go on as far as you want. That's what makes it really powerful. It enables ongoing conversations and builds upon previous results. In terms of the role ChatGPT can play with you, it could be like a personal secretary. It can take care of a number of repetitive things that you do. It's very creative. Its power comes a lot from its creativity. So ask it to write a poem, ask it to explain dialysis to a layman in a simple language, or ask it to crack a joke. The creative power is substantial. It can also be a great sounding board. It can help you think through the research problems. It's a great analyst. It analyzes data. In example we saw, it's extremely good at translations across languages. It can be a teacher, but it is not sentient. This is what I meant by saying, it's not intelligent. It has zero intelligence. It's not like it has zero intelligence. It does not know what it is saying. ChatGPT or any other generative AI tool simply works on probability. And the probability we say is the probability of the next alphabet which should come. So for example, if I ask this room, randomized dash dash, you're going to say clinical trials. You've learned, and you know that randomized is always followed by clinical. This is exactly how generative AI repeats or creates content. It has been trained on so much information that it knows that when I say what the dog dash, the fourth word has to be saw. That's a book by Malcolm Gladwell. So it knows that when I say what the dog dash, the next word is going to be saw. It's fully probabilistic, and there is no intelligence. So even the analysis it did of that image, entirely probabilistic, and this is very hard for us to fathom, understand, and people who've built it are on record that we don't know how it works. We don't know how it works, like how it's able to actually come up with such sensible answers. We know the science behind it, but in a particular solution, I don't know how it went from this question to this answer. So they don't know how it works, or they don't want to say. That's a big conspiracy theory that's there. Alternatives to ChatGPT, Claude, Gemini, there are many. These are the powerful ones. Gemini is the tool which was built by Google. Claude is built by a company called Anthropic, which is supported or backed by Amazon. and ChatGPT is built by OpenAI, which is backed by Microsoft. So these are the big guys. And not to be left behind, Facebook has created Meta. The good thing about, so there are, you know, specific advantages of each tool. The advantage with Meta is that it's inside WhatsApp. Most of you would have access to this inside your WhatsApp thing. And the area where Meta excels is personal experience. It's great at current news. So if you ask it something about, you know, Vinesh Fogart today, it will give you a far more sensible answer than any of these guys can. So these are different tools are getting better at different kind of things, more strategic about how the company wants to position them. Since Meta is inside WhatsApp, it makes sense for it to be very news oriented. So let me let's quickly do this and see, you know, how the tools work. I'll copy. I have this prompt so that we don't waste time. Yeah, so there is this prompt which says, can you list the most recent clinical guidelines in CKD, Indian American and European? You can be the best judge of the quality of answers. So I'm going to type this. So when you go to any such tool, you're going to have a chat box, which is where you put the prompt. What we've put in is the prompt. Can you list the most recent guidelines in CKD? And you just ask the question. We'll do the same thing with ChatGPT. For the sake of clinical questions or literature questions, Perplexity is one of the better tools. You can write it down. It's called perplexity.ai. Amongst these different tools, as far as literature is concerned, Perplexity is one of the better tools. You also put the same question there. So I look at Claude's responses first. Yeah, so these are the guidelines that it has identified. I am not sure if these are right, wrong. The thing is, generative AI is all about conversations. So the follow-on questions really make the answers better. So if anyone would want to, have a follow-on question, if there's a mistake, you can say this is not right. Or if you want to go deeper into, see, this is an example of, is 2012 the last guideline? It can't be, right? So yeah, so. So you just say, so it's very quick to apologize. It's very quick to agree, and it's not very reliable. And therefore, I always say that the golden rule of using GenAI is to use it in your area of expertise. Do not never use it in an area where you're not an expert, because you're most likely to be misled then, or you will never know when you're being misled, because this what just happened is called hallucination. It's a real word with GenAI, so it hallucinates. It just gave you an answer, and there's an even better example of hallucination we'll see again. I'm not sure if it will be replicable, because generative AI, unlike Google, is not replicable. Every time you ask a question, it starts from scratch. So I've had this typical mistake, and I don't know if we'll make that mistake again, but it hallucinates. And therefore, it's very important for us to use it more as a labor-saving tool rather than as an intellectual tool. To the extent it helps save time, to the extent it amalgamates content from different places, it's great. But to use it in an area where you don't have a clue is very risky. At this stage, the tool is not at that level, and which is also a reason why these tools are not FDA cleared or for clinical care, or they are not even allowed to be used in a lot of places at this stage. ChatGPT's answer was this. Yeah, it started with 2022, and the lengths of their answers will vary. I will see Perplexity. The advantage with Perplexity is that it gives you more questions to ask. So it actually guides you along your research. So it says now you can ask this, and if I click on that, then the conversation goes along in that direction. So this is just an example again. Similarly, you can do more examples. Can you share the 5 most recent clinical trials or things like that? I'm going to try this. So let's go to Claude. Saying, can you provide a summary of the following trials in nephrology? These are just names I picked up over the last 2 days. It'll do a decent job. And again, the power of the tool is in the follow-on questions you'll ask. You'll say, okay, what were the endpoints? What were the limitations? And those answers are really good. So you say, what were the limitations of Mentor? So that is that. But now I'm going to insert a trial which didn't happen, or at least didn't happen in nephrology. Yeah, so it'll make it up. So this is dangerous. This is proper hallucination. Yeah, you've got to be careful with this tool. It's right most of the time, but when it's wrong, it's equally confident, and so that's a problem. So yeah, let's see. I would hope not. Yeah, I didn't give Trinity. Oh, I didn't. Oh, I yeah, but so if you will search for this will be some different trial. So last time I came across something called Nobility, which was called as Trinity. Then there was a Duet, which was called as Trinity. So the thing is, this is 2 years old in public domain. There's a lot of development happening, and a year from now, maybe 6 months from now, these mistakes will keep reducing. But it's very pertinent to say that today we are at this stage. Maybe the way the models are trained and fine-tuned, they are not trained and fine-tuned enough to say no. They're not fine-tuned enough to say this seems to be wrong. They're trained to take things on face value, because the majority of the people are not trying to break the system. We are just doing this to make a point, and which is why if you are a nephrologist, you're never going to put Trinity inside. Most of the time, the answers are going to make sense.
In ChatGPT, can you insert a picture?
Yes. Yeah.
Can you just demonstrate this? You showed it in Claude.
We can put a picture. Let me see if I have a picture. Actually, I'll show you an interesting picture. I'll show you the picture first. So you'll appreciate. So this is the picture we are. So this is what we are inputting, and we'll just say, can you? Oops, sorry. Can you help read this? Actually, ChatGPT will, yeah. So.
But it says in Hindi, in English.
So there's some things in Hindi, but yeah. I mean, it's impossible to say whether it's hallucinating or right, because we can't read the prescription. We'll have to find the real author to see, but at least RL looks right. So. Oh, you can read it?
We also write
So, yeah.
First 7 are correct. First 7 are correct. The 8th one I am not sure.
I love the confidence that you have in this handwriting. So, yeah. So, quick word on limitations and ethical considerations. So, first is we discussed this accuracy and misinformation. Definitely a real thing at this stage. Second is when you upload these things, patient data privacy and your institutional privacy. These are two things to take care of. If you upload things, crop out or delete personally identifiable data. Just a word, don't paint out information. So for example, if you have a file, you'll put a white box on it. It's smarter than that. It can read content behind a white box. You'll actually have to crop out. You can't put a box. Fourth is disclosure. So if you've used AI in your research or especially in your writing, it's a good practice. Yesterday, I think we saw a couple of journals which make it mandatory. I think it's a good practice to disclose and sometimes it's mandatory to disclose. Fifth is a very big issue which we are going to see in the next 10-20 years. It's so useful, so powerful, so addictive that there's a real chance of people becoming less intelligent over time. It's something which I personally believe that policymakers should maybe ban people below a certain age from being allowed to use it because for a lot of us, our foundation has been built. We've learned things. We'll now use it. We understand the differences. For a lot of people, they are going to enter into this right away. They'll never build the foundation of a p-value or sample and population, and they'll go directly here. They'll get all the answers. So this is a big issue. And finally, copyright infringement. There's a very big controversy around OpenAI team using paywalled articles for training their content. So you will get answers on paywalled articles here. And there are multiple lawsuits going on as we speak. Second is originality. So if you submit something which you've not written, I think that's a gray area. It's not plagiarism because you're not copying someone. It's generated by AI for you. It's not plagiarism, but it's not yours either. That's a gray area. And unintentional plagiarism is a big issue. So a lot of times what ChatGPT or Claude will throw out is somebody else's content verbatim. You will not know that you have copied it. You believe that it's original because it's come from a tool, but it's actually found to regurgitate exact blocks of paragraphs from someone else's content. And so you become, a victim of unintentional plagiarism. These are some things to worry about. Yes, but you'll have to ask paragraph by paragraph. And so you put in a paragraph and say, is this sourced from anywhere else? But how much can you rely on it is a question mark. So like a positive hit is a positive hit. But if it says no, then are you sure that that's the right answer? So quick difference between Google and ChatGPT. I'll pass through this. But one, ChatGPT is about ongoing conversation, about threads. It actually gives you the answer. Google gives you the raw materials. It'll give you 30 or 3,000 sources, but you will have to do the work. ChatGPT gives you the answer, and it really appeals to the human laziness, which explains the jump to 100 million users in 2 months. It provides the dish straight away. Also, in ChatGPT, the human effort is free. What we mean is that the better the prompt you write, the better the answer is going to be. On Google, we don't waste more than maybe 5 to 10 seconds in writing the query. But on ChatGPT, if you will spend maybe at least 5 minutes drafting your prompt, it will give you significantly better answers. can make big mistakes. Google does not make mistakes because Google does not give answers. It just shows you the way. It might link a false blog, but it's not Google's mistake. It's that blog author's mistake. Whereas ChatGPT is actually giving you an answer. So to write better prompts, these are just some general rules. Keep 5 things in mind. So when you prepare a prompt, give it context, as much context as you can. So things like so if you want to let's say create a presentation outline, then the context would be who's going to be my audience, or how long is the presentation. So that's all context. So give it as much context. Think of these tools like a research assistant. If you have an RA, you're going to give that person a lot of context. You can't just give a one line, because if you will give a one line, you'll come back with something not entirely right. Second, allow it to adopt a role. So you say you are a trained nephrologist with 20 years of experience. So that is very important. It gets in character. Third is output. So on output, you can specify whether you want long or short, whether you want 100 words or 1000 words. You can specify whether you want a casual tone, a persuasive tone, a sarcastic tone. So, express yourself. And you can also specify whether you want the answers in a table format, in a list format, in a flowchart format. Flowcharts are not very good, but you can specify style, you can specify length. But so this is how the prompt is constructed, but post the construction of the prompt and the first iteration, give it feedback. So once it gives you the answer, give it feedback. Say, this is great, but I don't agree with this part, you could curtail this part. So talk to it. That's where the answers get refined really, and keep experimenting. So this is an example of a prompt. So if you want to deliver a lecture on a topic, it's not simply saying do this lecture. So it is, you're a senior nephrologist with 25 years of experience practicing in Mumbai. And this all allows it to contextualize the answers to, maybe there are things specific to your region. So that's the role. Second is lecture on managing CKD in pregnancy to an audience of trainee nephrologists. So I'm not doing it in an MBBS class, I'm doing it in a DM class, and the answers will definitely be different if you change that word. So that's context. And then the output is, it's a 20-minute talk, exclude irrelevant details, focus on practical implications. So what? This is just me, blabbering to it. All of this is not necessary, but the more you write, the better the answers generally come. Right, so this was more of an introduction. How much time do we have? Yeah, so this was part 1. I wanted to talk about AI in general.
We can continue those who want to. We can continue.
I'll show you. So we've seen perplexity. So so the research process you all know. So there is background research and review of literature. There are 2 apps for that, Heuristica. I mean, there are a lot of apps for that, but there are 2 which we would have seen. But I'll skip this one because perplexity we have seen, and Heuristica is more fun. Rather than useful. So, at the end we'll check it out, or just go to Heuristica website and see their video. ResearchGeek is interesting. So, it helps you to generate research ideas and refine your research problem. And it also helps to check if the problem that you have now identified has been adequately addressed in literature or not. So, it's pretty useful. The third one is also useful, Research On. It's used for building protocols and building questionnaires, and also drafting your manuscript. The fourth is analysis and insights to analyze your data. And the fifth is again manuscript drafting and presentations. So ResearchGeek is a paid tool. It costs about 750 rupees a month. The way I would look at it is, I would take it for a month when I'm figuring out what I want to do. And discontinue it afterwards. So that's okay. Research On is also a paid tool. For one study, average cost is going to be about 3,000 rupees, 4,000 rupees. Most of these tools, so ChatGPT and Claude are free. So they have a free version. ResearchGeek and Research On don't have a free version. But ChatGPT and Claude, the free version is good enough if your usage is not heavy. If your usage is heavy, as a thumb rule, all these tools are $20 a month. ChatGPT, Claude, Perplexity, Gemini, all of them are at $20 a month, which is roughly 1,800 rupees a month. Depending on your usage, this may be completely worth it or tad expensive. So it really depends on usage. These prices probably are coming down, but I'm pretty sure that in 6 to 12 months, everyone will, as default, have at least one tool that they are subscribing to. They are very powerful in saving time. So before I go to the tools, this was one very powerful use of AI. So ChatGPT, the current powerful model is called 4o, and 4o is available to free users, but after a certain amount of usage, it brings you down to 4, and you'll never know that. So the quality of responses will become poorer after a point. Same with Claude. Their default version, the best version is 3.5. It's called Sonnet, 3.5 Sonnet. So if you want 4o forever, like for every conversation, you need to pay. If you want 3.5 Sonnet for every conversation, you need to pay.
So all of these GPT tools, we need to download the apps on the phone when we use them?
You don't need to. They are on the web, so you can use your Chrome or Safari on phone.
They don't remember you if they are on your phone?
They will remember you because you'll have to log in. So even if you go to Claude.ai, you'll have to create your account first. Once you have created your account, it will remember your conversations and everything.
Claude is free, no? Claude is also free.
Yeah, Claude and ChatGPT both have free versions, and the free version will give you a decent experience. So yeah.
If you improve an answer by asking any questions, does it use that and for everybody else's questions?
Yes. So anything you do on any of these tools, the information is going to train the model further, which is why it'll keep getting better, and which is why we have to be careful about what we share. ChatGPT has a mode called temporary chat. So ChatGPT has a mode called temporary chat, which is like incognito for Google Chrome. So when you turn on temporary chat, for the period that's turned on, your content will not go out. So you could use it intermittently. So there is this company called InSilico. They actually have their own internal, they created their own AI called Chemistry 42. And Chemistry 42 is like ChatGPT but for molecules. So what they were looking at was to create an novel molecule that will help with IBD. They figured out that we want a molecule which reduces the expression of PDH, and so that's a receptor, and the model came up with 1,000 combinations of carbon, hydrogen, oxygen, and nitrogen, and these don't exist. The model is saying these 1,000 combinations will suppress PDH, and then they gave it more constraints. They said I want oral, so 1,000 became 100. And then they gave it more constraints, and finally they came with this one molecule ISM 5411, which meets all their constraints. They have now synthesized it, and this is now in phase 2 trials. So when this comes out, this will be an entirely AI generated molecule.
Does ChatGPT has any truncation?
As in?
Like truncation that the research we use, inverted commas or something.
I didn't get the question, sorry.
Suppose
So.
if you want to have some information specifically, then is it something?
Oh, okay, like emphasis. Yeah, it does. So it does understand those things. So if you will put things in inverted commas, it'll lay emphasis on that. But it's not as clear as Boolean. It's not going to, this does not work like search. It's going to give an answer. It's not going to show results. So if you will say, but it's more conversational. So you can, instead of not and or, your language will take care of it. So you can say, give me papers from BMJ but not from NEJM. And it'll understand that. It will not give you NEJM papers, it will give you BMJ papers. So it's, in a way, it's a step forward from Boolean in that it's very natural language. but in a way it's not harsh. It's not as rigid as Boolean is. So yeah, so that was one. We'll skip this. I'll show you ResearchKick and how it works. Yeah, so ResearchKick looks like this. You need to say what's your research project about. Anyone? But that was more of review of literature. Let's say if you want to publish a new paper, if you've been thinking, if anyone has been thinking, just keywords. And the idea here is two things. One is to refine the problem. So you start with a general idea. It'll help you refine the problem. And two, do a literature match. That has this problem been, like, will this be an original contribution, or has it been answered adequately? So any example?
Any topic. We can say use of a white noise machine to improve sleep. So can you use a white noise machine to improve quality of sleep?
Can we use a nephro example so that, like, it's probably more because it'll give you 15 options, and to, like, appreciate the breadth in which it thinks, it'll be much more appreciable. It's in nephrology.
CRRT versus continuous renal replacement therapy. CRRT versus peritoneal dialysis.
That's it.
In critically ill patient. In DA. Okay, fine. This is fine.
So here you see that it's given me 4,700 credits. So every month you get 10,000 credits for that 750 rupees, and some credits will be deducted. Now what it does is it looks at the query you gave from 15 different angles. So this is a more, it always starts with a more molecular angle. So there's one way to answer, draft this research. What are long-term outcomes on renal function in patients with CRRT compared to those with PD? This is probably closest to, like, what a normal question would be. This looks at inflammatory response in cytokine profiles. This looks at cost effectiveness and resource utilization differences. This looks at timing of initiation of CRRT, electrolyte and acid-base balance, complications, and so on. So it will give you 15 ways in which you would want to look at it. Shall I choose the second one, which was the broadest? So here you have 3 options. Copy is okay, but you can refine this question. So do you want to refine it for a certain age group, gender, geography? Then you can mention it here. So maybe, you want to do it for Indian patients. Anything else? Children? Right. So you refine it, and it'll generate again 15 versions, and 15 or whatever. It's not always 15, but so is this okay? The first one? Survival rates and quality of life. So I'll do a match available literature. It gives me 4 options, of which databases you wanted to match against. For now, I'll just choose PubMed and try to match. Sometimes when it takes time, it gives us confidence. So you can see this here. So it will give you some example. Sorry. This thing is stuck. I'm waiting for this answer. So what it will do eventually, so you can, wherever it's saying found 1, found 10, you can collapse it and see which paper it found. But it also summarizes, which it will do once it's ready. It'll tell you the net answer, that this has been adequately addressed, this has not been adequately addressed, which is a good point for us to start with. It's difficult to say whether this is actually processing or stuck. So yeah, here. Oh yeah. So this used up the credits, but this is unusual because it generally uses about 1500 credits every time you match literature. So matching literature is expensive compared to generating questions. So generating questions, it uses about 100-200 credits out of 10,000. That's not much. But matching literature is expensive, but it's not this expensive. So anyway, I won't be able to see this right now. Yeah, we'll have to move to the next one. So I'll show you research on. Sorry, I'll need my phone for that. So this is how research on looks like. You essentially start by creating a study here. So when I click on create study, study name is where you put in, let's say we do the same thing, CRRT versus PD in AKI. So you put your keywords here. These are fields which can be anything. So let's say 456. Study alias is CRRT AKI. Type of study would be research or anything. It can be single centric. I go next. My unique identifier is unique number. Consent required, no. And I save it. Now when I click on this, it will start generating the study protocol. It will take maybe a couple of minutes. Not a couple of minutes, actually a few seconds. Research on .ai, research on .ai. So it started generating a basic protocol. Aim is to compare efficacy and safety. So we didn't say efficacy and safety, but that's the AI doing its job. Objectives: compare the rate of renal recovery between CRRT, evaluate incidence of complications, assess the impact on patient survival. Hypothesis that it will result in faster renal recovery but higher complication rates compared to PD. Study will be a prospective randomized control trial. Setting, population, so eligibility criteria is confirmed diagnosis of AKI, ability to provide informed consent. Exclusion criteria is this. Outcomes are so and so.
Research methodology workshop is not needed.
So
this would be the last research methodology.
Some of these fields will be empty, which are for you to type, or you can use another AI tool to copy paste things here. It also starts with a abstract to start with. Yeah, so it starts with an abstract. It starts with an introduction. It starts with a rationale for this study. What are your aims and objectives, what patient recruitment strategies and so on. A very basic review of literature to begin with. So it starts, so this is just a beginning, but this gives you the dopamine kick which you need at the beginning because now you've started. And so one good part is this. The second really interesting part here is the form builder. So when you will create a form to start recruiting, you can just click on generate here. So this uses AI to create a questionnaire for you.
Basically, no one has any excuses anymore for not writing assessment.
So it has created this. If I click on see more, so these are some questions it has created. So participant ID, age, gender, primary cause of AKI, comorbidities, baseline serum creatinine, baseline GFR, Apache 2 score, initial hemodynamic stability, urine output into rifle criteria, vasopressor use. Yeah, so you can select all and then maybe remove a couple if you need to. You add it to your form, and then here you can change them, but also each type has a different input type. So this is like a multiple choice, some are multi-entry, and so on. You can change the questions here. Now this is the pilot phase of your study where you are free to tinker with things. You're free to tinker with the questionnaire and all. In the pilot phase, you're allowed to take 25 entries. Entries are taken with the mobile phone. So it has an app companion where you do the data entry, which is great for the point of care where you're going to actually enter the data. When you're satisfied with the questionnaire and the study design, you move from pilot to active phase. After which you can't change the questionnaire, and after which you can't change the data also. So no data can be changed once you're in pilot, once you're in active. So this was a quick demo of research on. So right now the analytics are here restricted to descriptive analytics. So it does not have statistical at this stage, but I'm sure they will add that soon. So. Yes. You can export the data. Yeah, whatever data is captured here can be exported. You can use it in SPSS, Excel, wherever you need to.
That would be the easiest part of the whole process.
For them, for AI, yeah.
You're saying you can just download this on a tab and just give it to every patient and ask them to just
Someone from the research team, not to a patient, but yeah. So your research team can do the data entry. Yeah. Finally, I'll just show a use case for a statistical analysis. So I have a dummy file here. So I have a dummy data file which I created for this. So I would just say, I'll copy the prompt actually. Can you, and I did a very loose prompt. The prompt can be much better, but the idea was just to. So initially, it just describes the information that you have. Yeah. I want to compare differences in prevalence of hyperthyroidism across genders. Is it possible? Yeah. 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 So it will do it. Yeah.
This is a paid version or
Is it replicable? I mean, reproducible, like you do it again the same thing?
Yes, yes. With data, yes. Yeah.
This is a paid version?
Mine is a paid version, but this will work on the free version. Yeah.
On the free version, it works once. Like it will analyze
They have not specified what are the limits on a daily basis. So, but it works. These tools are getting more and more powerful. So, yeah.
It will answer your data question once. Like it will do one analysis and then.
No, more than that. More than that.
No, actually it puts a limit to the amount of times you can upload a file.
That is the one.
And then it tells you to come back after. Yeah, after
Yeah, and different tools have different. So Perplexity says that in a 4-hour window you can only do 10 questions. So they have all different rules, but just use it.
A different login ID if you,
Yes.
if you have different email.
Correct. So, so there are more. There will be more Indian ChatGPT accounts than our population. So, right. So I think that was it. Okay, sorry. I wanted to show you GPT-0. So GPT-0 is a tool where you can put in a block of text and it will tell you whether it was AI generated or not with very good accuracy. So
Journals used to
this or a version of it, yeah. So yeah, there are multiple tools, but GPT-0 is great. There's something called Turnitin. So Turnitin is there. No, it's just AI generation. So Turnitin is both, but GPT-0 is just AI. So this will just tell you if it's AI generated or not.
Any comments from the chat?
Yeah.
We have been commenting throughout the presentation, so, but brilliant presentation. Thank you so much. It was eye-opening.
Thank you. Just a quick word on Medflix. So the platform that I run, so it's a live learning platform for doctors. It has a section called AI Assist inside it. We have 3 use cases built in AI Assist right now. It's free to use. So the 3 use cases are differential diagnosis, drug interactions, and drug dosages. So you give it a drug name, patient type, whether pediatric, adult, pregnant, and you give it the condition for which you want that drug's dosages. So it will give you detailed drugs with references, and also drug interactions and also differential. So for differential, you can give it just 2 lines of history, or you can give it some investigations that you have, some sign symptoms. It will give you a very good differential diagnosis. So no, it uses ChatGPT. It uses ChatGPT at the back. So, but it takes away the effort of writing the prompt every time. So you just copy paste your thing. Yeah.
So is there any way we can safeguard against AI hallucinating?
You could build in some strength in the prompt you write. So you could emphasize that. So for example, you can say only refer to peer-reviewed journals with a high impact factor. Do not cross-check twice what you are saying. So that's the only way to make your prompt stronger and stronger. At the back end, on the technology side, they are fine-tuning it all the time. I mean, their number one priority is to prevent this. So they are building in guardrails to make sure that happens lesser and lesser. But I mean, beyond the prompt, there is nothing that we can do with it. So the prompt is your only tool. So the better the prompt you write.
Just on a lighter note, when will it start making PowerPoints?
It makes. Yeah, there was a tool that was on that slide called presentation.ai. There's something called beautiful.ai. There's something called gamma.app. But wherever image generation is concerned, the current AI tools are not good enough. So they are more of a theoretical inclusion in the conversation, but they're not good to use. Anyway, the value of a presentation is more in the content. So, the content will be there. Just put it on a black and white slide. It's okay. So.
I just wanted to add to what Dr. Weber was saying. So ChatGPT generates false references a lot of the time. So if you are don't ask it for references is If you actually go and search for them on Google Scholar or on PubMed, they will not exist.
But it's still better to ask for references and then check instead of not asking.
I mean, in my experience, most of them have been
So Perplexity is much better.
Perplexity is much better.
Yeah.
How many AI tools are there like this now?
Tens of thousands. So, yeah. And ChatGPT has this thing called GPTs inside it. So GPTs are apps. So just like your Android phone has apps, so ChatGPT has apps. So when you go to ChatGPT, you can explore GPTs. And these GPTs are specific tools for a specific purpose. So for example, I've created a GPT called Homework Guru. So all you need to do is take your kid's, photograph. Let's say, so my daughter is in 5th standard. So her maths textbook, take the photograph of an exercise page and take 10 photographs of 10 different pages and then say create a math paper for this. It's excellent. So and you can specify the difficulty level and so on. So these are mini apps. So that every time I don't have to write the whole prompt, because when I created it the first time, I gave it some instructions of what not to do, what to do. Like for example, don't include answers in your thing, and so on. So there are thousands of apps, GPTs now built. So inside just one tool called ChatGPT, there are 10,000 tools, and then there are many tools. So.
Just about that PowerPoint. PowerPoint you can add these AI tools to PowerPoint and ask them to do it for you. And then they'll just enlist that. So if you can click just on
Yeah.
say that's called as pilot in
Right, Copilot. Yeah.
and it will just give you outline and content.
Sure. Yeah, that's right. Yeah. So Microsoft is because Microsoft has built Copilot and they have full access to OpenAI. So they are trying to build it more and more in your workflows. So inside Word, inside PowerPoint. But most of these I think will need a Office 365 subscription to work. So yeah.
Office 365 is worth it. Actually. Only 3,000 rupees per year.
Yeah.
It's only 3,600 per year.
Okay.
Some version is free.
No. 1 month trial. Right. Thank you so much.
Thank you, Dr. Rohan, for such a fitting finale to an excellent program organized by Khanna Sir, Mumbai Kidney Foundation and support of MNG. Thank you for all the delegates from traveling all over the city and all our faculty who've come over a busy weekend. And thank you to EverVital for supporting this program. And we'll proceed to lunch. I think it's on the right hand side.